Morning, everyone. Morning. Welcome to National Union Building and Break Up Big Medicine. We're going to get started in just a few minutes. So once you get your coffee, please take an open seat. Also, very vital information, there are restrooms one floor up on the 5th floor and on the 2nd floor. So when you exit, either up one staircase or the elevator or down to 2nd.
Hey. Hey.
Hello. All right, if everyone can take their seats, we're going to get started. All right. This is first of all, good morning, everyone. I'm Nidhi Hegde. I'm the Executive Director of the American Economic Liberties Project. And along with our co-host, the Century Foundation, I want to welcome you to our healthcare convening. I will say that in all my years of attending any kind of conference, no one has been this on time. So well done. And it's a packed room. And also, thank you for taking the stairs up. So a little healthy start to your morning. We're going to get cozy and comfortable today. This is, roll up your sleeves and talk about the ideas to take on big medicine. So get settled. There's coffee in the back, bathrooms on the 5th floor and the 2nd floor, and we have a packed agenda. So let's get started. In February 2024, Nicole, a 32-year-old woman in Connecticut, walked into her pharmacy to pick up a prescription she had filled dozens of times before. A prescription her psychiatrist wrote to treat her bipolar depression. But that day didn't go as planned. Nicole's insurance wouldn't go through because a Change Healthcare computer thousands of miles away had gone offline. Change Healthcare is owned by Optum, which is owned by United Health Group. As Change failed, patients like Nicole couldn't fill their prescriptions, and clinicians across the country couldn't be paid or process claims. Some practices went weeks without revenue, and Optum, sitting on billions of dollars in cash, offered them loans to stay afloat. One doctor in private practice in Pennsylvania, who typically submitted $600,000 a month in claims, received a $4,000 loan offer from Optum. She called it an emotional slap in the face. I might have called it something else. The failure didn't cost United Health anything. In fact, they found another way to profit from their own mistake with their loans and bury independent practitioners. This is a classic example of corporate monopoly that is both too big to fail and too big to care. The American Economic Liberties Project was built to fight such monopolies that strip ordinary people of their economic freedom. Healthcare was one of the first sectors we examined. We looked at hospital mergers, big pharma patent abuse, pharmaceutical middlemen like PBMs, GPOs, and wholesalers, private equity roll-ups, and the vertical integration between insurers and physicians. It all led back to the same problem, big medicine. Today, 6 companies dominate the healthcare industry and booked nearly $34 billion in profit last year. This is the result of decades of neoliberal policymaking by both political parties based on the flawed premise that private insurers would be the best stewards of our healthcare system. Neoliberals have had 50 years to prove their hypothesis, and here's the truth. Healthcare is more expensive and less accessible than ever. We need a new treatment plan. So that's why we launched Break Up Big Medicine, to develop solutions big enough to match the crisis. During the Great Depression, this country broke the power of the big banks that caused the crisis. We need to do the same in healthcare. Today, a patient walks into a system not designed to care for them, but to process them, because big medicine cares for Wall Street, not us. Healthcare should be between a practitioner and their patient, not controlled by empty MBA suits. We believe we can get back to that. Not by chipping at the edges with transparency reports or subsidizing insurance conglomerates, but by breaking down and rebuilding the system from the ground up. One that restores power to clinicians, dignity to patients, and makes clear once and for all that healthcare is not a product to be rationed or cost-contained for the benefit of shareholders. It is a right. The good news is that there's overwhelming public support, and policymakers from both parties are already beginning to act to break up big medicine. Several structural separation bills have been introduced. But bills and ideas are meaningless until they become laws that are faithfully enforced. This brings me to why we're in this packed room today. For years, each of us has chipped at big medicine alone. Nurses, pharmacists, independent doctors, patients, employers, and even policy wongs. Each of us with our own piece of the fight, our own tweak, our own bill. We will never achieve the big policy wins we need without a power-building political movement behind us. So today, Economic Liberties is really proud to bring together 22 national organizations representing every corner of American healthcare into that force. So you'll hear from these coalition members, from the people who've done the research and the people who've lived it. You will hear ideas on how to attack the big medicine problem. This movement starts now, and I'm so glad you're here with us. Thank you. So first up, we're going to have a video from our close partners, More Perfect Union, that dives into the big medicine problem.
And they can't believe that insurance companies are acting this way.
When we could no longer actually take care of the patients.
They have left people devastated. People have died. People will continue to die. They sold out this poor community for money. And that's something that I think can never happen again.
Good morning. How's everyone today? It's great to be in a packed room on this very important topic. So my name is Mindalyn Anderson. I'm a business owner here in Washington, D.C. with Mirror Group, which is a small consulting firm where we focus on evaluation, learning, and strategy. Skyrocketing healthcare costs have significantly strained my business. Unfortunately, the Mirror Group is now one of the nearly 25% of small businesses that have been forced to drop health coverage for our employees. I've always prided myself on offering good jobs with living wage salaries and multiple benefits. When the cost of benefits rose significantly, we first tried to increase the portion that employees paid, but over time it just became unsustainable. We made the difficult decision to drop our health plan and to shift our labor force from full-time W-2 employees to 1099 contractors. As a result, several employees left our team in search of a job with stronger benefits. My business is in a weaker position now, as most talent we attract can only split their commitments between our work and other employment due to cost of living and the cost of and need for health insurance. I can't blame them. I'm a wife and mother of 4 young children, and I know that health and other benefits make a big difference when choosing a job. So as a business, we continue to monitor healthcare costs and see what we can do to help our workers. But that's just the surface level. What we need is a root cause solution that makes high-quality healthcare unaffordable and inaccessible for millions. That is just not acceptable. So that's why I'm here today as a representative of Break Up Big Medicine Coalition, member Small Business Majority. I want to be able to offer health insurance again and grow my business. But that can't happen until we address the affordability crisis facing our healthcare system. It's time for us to break up big medicine so that the small business community can afford the access and care that we need. Thank you for hearing a bit of my story. Now, I have the honor of introducing Eva Marie Stahl. Small business owners and employees aren't the only ones being crushed by big medicine. I'm pleased to introduce Eva Marie Stahl to moderate the next panel on how big medicine is harming both practitioners and patients. Eva is the Vice President of Policy, Engagement, and Research at Undue Medical Debt, where she oversees the development and implementation of their policy work and programming. Eva works to ensure that the voices and experiences of people with medical debt are centered in solutions to the crisis. I'll turn it over to her now. Thank you.
All right, is that on? It's on? Great. All right, good morning. It's delightful to be here today. Let's get into this. So my name is Eva Stahl. I'm with Undue Medical Debt. It's a pleasure to be here with people that are on the front lines and part of the healthcare infrastructure to talk about corporatization and the harm that they feel in their daily work life, as well as caring for other patients. At Undue Medical Debt, we relieve debt for people across the country and work to pair that with upstream change to end medical debt for people. And we really are at the tail end of corporatization of healthcare, right, where patients are increasingly feeling the pain of the cost of care, most notably, as we just heard, by losing insurance because it's just not affordable, right? And we see this every day in the stories that we hear from patients that we help that can't afford their bills and end up in debt. So I'd like to sort of start today by talking a little bit with this great panel, which I encourage you to take a look at in your agenda, about their experience representing dentistry, pharmacy, and emergency medicine. And we're going to talk a little bit about why they came to this issue and how they're experiencing it on the ground. And let's start with Dr. Adair and talk a little bit about independent practices or being sort of swept up by these massive corporate purchases in the dental world. Can you talk a little bit about how you're experiencing that on the ground and the care that you're able to provide?
Is this on? Hi, I'm Dr. Amy Adair. I'm a board member of the Alliance of Independent Dentists, and we are also a part of the Coalition for Patient-Centered Care. I am a second-generation pediatric dentist. I also served in the Navy for 8 years as a dentist. When corporations take over a dental office, we see a shift away from personalized care towards generic care and algorithms. The most common complaint that I hear from patients when they come to me for a second opinion is, I felt like I was rushed and it was all about the money. It just didn't feel right. Often these families arrive at my office extremely anxious because of this past negative experience. And I can only imagine how hard it was for them to take a second chance on us. And I can't imagine how many just decided to not go back after that negative experience. Independent practices are known for taking our time with our patients. When we take our time, when we explain everything thoroughly, the families have a clear understanding of need, and it's often at a much lower cost compared to the corporate office. Corporations are not interested in dentists investing this kind of time with our patients. They're in the business of maximizing daily revenues. Dentists in these offices feel immense pressure to produce as much as possible, to the point where corporations will send out monthly emails to their providers, and they rank the providers from highest producer to the lowest producer. And that's very scary. And often that causes these, this entity, this organization to add revenues by doing add-on services or extra possible services that may not necessarily be needed. And this leads to higher out-of-patient costs. My team in my office also notices a shift in their inter-office communications. That longtime front desk administrator all of a sudden is replaced by an AI assistant or a new employee who does not have that industry knowledge. When we are requesting patient records or radiographs, it can be very burdensome to get that information, and it's often incomplete. Dentists are harder to get a hold of to just have that one-on-one conversation about the patient. All of this is extremely disruptive to the continuity of care for our patients. These subtle nuances really negatively affect the quality of care for our patients. When staffing, scheduling, and billing are managed by the corporation, there is a palpable downstream negative effect on the quality of care and the goodwill of our offices within the local community. That breeds distrust, and that is dangerous. This affects every single one of us. And at the end of the day, we're all patients, and we need to break up big medicine.
Thanks, Dr. Adair. I now want to turn to pharmacy. Monique, you have really helped lead this effort to bring light to the fact that so many local pharmacies are losing their footing and their anchors in our community. Can you talk a little bit about how this feels for your workforce and these essentially small businesses that are struggling with financialization?
Yes, thank you. So my organization, PUT for short, was founded 15 years ago by independent pharmacists who began to see this very poignantly in their own practices. They saw this writing on the wall. So that was 15 years ago. Naively, we thought if we could just get attention on the problem of pharmacy benefit managers, there would be such outrage that it would go away. It would get fixed. And what we discovered, as has been said earlier, is not just that they're so entrenched that they're too big to fail, they're too big to jail. They have incredible, crimes against them. And what that plays out like for pharmacists is, for example, what happened this week. So on Tuesday, we were in a small community outside of Pittsburgh where we had almost 300 patients show up for a town hall. It was in support of their one pharmacy, this one pharmacy that was started it was a family pharmacy. She's a second-generation owner, but this young woman at 25 had brought a pharmacy to this tiny community and then transformed an old sewing factory into a pharmacy, the only grocery store in the area. There's a little Subway in the back, a place where people can get coffee. But it has become the hub of this community. And 60% of her patient base are on Medicaid, and she can't serve them because Express Scripts arbitrarily, and it was arbitrary, cut them out of the network. So here's all of these people who depend on this pharmacy. It's a beautiful but long 10, 20-mile drive to the nearest town with a grocery store of any kind. A lot of the people that came to this were people who needed to get a ride to even be there, and they were there because what they wanted was just to be able to use the pharmacy of their choice. Now, for the provider, and we talk a lot in my organization about the patient impact, but I do want to talk about the provider and what this is like. So a pharmacy owner, a pharmacist, can't talk to her employees or her patient base about what's happening. Pharmacy owners carry these massive burdens. I know so many that have had to take a second mortgage out on their house to make payroll because of this, and the stress that is associated with that. I have a pharmacist whose side gig. I have pharmacists with bizarre side gigs, cute but bizarre. One of the most painful for me was finding out that one of my most treasured pharmacists has to clean houses to make ends meet while she's making payroll for her staff. There's another one in Georgia who has a bakery going. She makes more money on a cup of coffee than she does on most prescriptions. And this is the hardest thing to get across, that you can't ever sell enough toothpaste to make up for this loss. And yet, pharmacists, just like every other medical provider out there, they went into this because it was a calling. It's a noble profession. It's hard. They carry a lot of student debt when they first go in. And what they get turned into in the public's eye are pill counters. And I promise I'll wrap this up, but my best friends work at Sandia National Laboratories. They are literal rocket scientists. And the arguments I've had with them about pharmacists being more than pill counters, like I shouldn't be having this conversation, but that's what societally has happened because of corporate medicine. They've turned our providers into humanless beings whose sole jobs are to prescribe, and they're accused of overprescribing, and then pill counters. And yet the reality is they're caregivers who are looking out for you. And if they're working in big retail chains, we're starting to discover that they're on their feet all day long. They barely get breaks. They're expected to make impossible demands, and they're expected to do this day in, day out with a smile on their face, and the stress is just too much. And on top of that, as small business owners, they're being pushed out, and it's wrong. We absolutely have to break up big medicine.
Thank you, and I think we can all sort of relate with those stories, right, from our own personal experience as well. And before we go, I want to talk more about moral injury in a moment, but Dr. Norton, I'm hoping you can also talk a little bit about, because you're at ground zero, right? You're in the emergency room. This is the place that people rely on as well as being a barometer of what's happening in our communities. Can you talk a little bit about what this feels like when so many staffing companies are taking over?
Yeah, definitely. Thanks. I'm Dr. Vicki Norton. I'm the president of the American Academy of Emergency Medicine. And we've been fighting corporatization for over 30 years now. We saw it happening first in emergency medicine. We were kind of the canary in the coal mine. And some of our staffing companies were the first to sell out to private equity. And that's where we started seeing the harms multiplying, thousandfold. But the emergency department is really the safety net for our healthcare system. We are the ones that catch all the patients falling through the cracks. And the reason they're falling through the cracks is because they have decreased access to care, because they're uninsured or underinsured, or they don't have access to specialty care, or their insurance won't approve the care, or they can't afford it. And that basically translates to more ED visits. We have over 155 million emergency department visits in the country every year, and that number goes up every year. So we are basically absorbing all of the ills of the system, and we're seeing sicker patients. So as a result of corporatization, it's fundamentally changed how we practice emergency medicine. We have these large private equity-backed staffing companies that are beholden to investors and not patients, and they're dictating how we care for our patients. They're telling us how fast we go, how much staff we have, and basically telling us you need to spend less time with patients because we have to hit our metrics, we have to hit our numbers. They're telling us that the patients all have to be satisfied. I mean, when people are dying, I'm less concerned with if they're satisfied they got a pillow than whether, than taking care of them and saving their life. So, these are the types of metrics. So again, you're reduced to a number, and so that impact is felt by physicians, and we're experiencing burnout as well. But really, the biggest thing I think physicians feel is the loss of autonomy. We know what's best. We train. We know what's best to treat patients. We know how to care for patients. But we're being told to do things different than how we were trained to. And that loss of autonomy leads to physicians not being able to be advocates for their patients. And this is a big deal, because especially in the emergency department, if there's a patient safety issue, it literally is life or death. And yet physicians are silenced. They have no due process when they work for these staffing companies. So essentially, if they bring up a staffing issue, they're fired. And I'll tell you a story about my friend in Florida, who was one of the reasons I got into advocacy. She was working for one of these staffing companies at a for-profit hospital, and she went in for her night shift, and the waiting room was full of patients, and a patient sat in the waiting room with a stroke for over 4 hours, and they couldn't get to the patient in time to give them life-saving medicine. So this was devastating to her. She's like, she just got out of residency training, with a huge amount of debt on her. She had 5 kids. She was like, I care about my patients. I want to advocate for them. But essentially, as soon as she did, she lost her job. So she spoke to hospital leadership, and they said, oh, great, thank you for telling us, and told the staffing company. And because the staffing company did not want to lose their contract with the hospital, they fired her because she was threatening their contract by bringing up a very valid patient safety issue. So this is the kind of thing where doctors are being silenced. They don't have due process. And patients are suffering because these for-profit companies are jacking up prices. They're charging patients more. So when you have an emergency, you're not shopping around for the best price. So unfortunately, one emergency can lead to tens of thousands of dollars of debt for a patient. One injury or illness, and you're in medical debt. And we don't want to see that happen to our patients. But we've been separated from the finances because we're mostly employees now as physicians. Most of us are employed, and we're not seeing the finances. So transparency is important too, but this loss of autonomy and not being able to advocate for our patients is a huge issue.
I can really appreciate that, and I think particularly working with people that are struggling with medical debt on a daily basis, it actually just reminds me of a story. We talked to a woman last week, Amy, that was had medical debt. We abolished for about over $1,000 and had multiple surgeries and ended up in the emergency room, whereas many of the patients that we help do, and you're absolutely right that they end up with thousands and thousands of dollars of medical debt, which we can relieve, but we really need to make sure that they don't have it in the first place. So let's talk a little bit about patients, and let's talk a little bit about moral injury. So maybe Dr. Adair, we can start with you. Just really, can you think a little bit about how this, and talk to us about how this translates into patient experience? It feels like a very dire situation. How is this showing up for patients, and how they are accessing quality care, and whether they can access quality care?
For patients, I think what this is affecting is they think that they're going into an office to get that personalized care, and they don't even know whether this office is owned by the doctor that is treating them or the corporation until they've already almost been sucked into the system of that, because these corporations are hiding behind entities that look like they are privately owned. And I think that is the very beginning of distrust. And as that, they kind of go through that system feeling like that number, and they start to question whether something needs to be done or whether is this being done for this company to make money. That is going to prevent them from wanting to go in to just get their regular preventive services. And we all know that prevention is the key to lowering overall healthcare costs.
That's really helpful. And I'm thinking about, Monique, something that you said around, accessing medication. Can you talk a little bit about, how does this affect patients in getting not just the medications that they need, but also adherence and staying healthy?
It's a real challenge to have a patient adhere to medication, particularly when it's a new illness, chronic illness, or the medication itself may present, uncomfortable side effects. It's already a challenge. And then when a patient comes to a pharmacy and they discover that pharmacy was allowed to fill their prescription one time, and now they have to go to mail order. And they have to have 90 days, because 30 days for some reason is way more expensive than 90 days. It starts to create, I think, as Dr. Adair said, a lack of trust. And, as you were speaking, I was reflecting on the rather ironic commercial that GoodRx puts out with the young mother who comes in late at night at the pharmacy and like, oh, please, let the medicine not be too expensive. I think that sort of fear has given way to resignation and hostility now. And they're starting to question, like, well, do I even need this medication? And they think it's the pharmacist's fault. And again, I find so much about corporate medicine to be just so frustrating and ironic. The video spoke so well to it. It's private equity. It's not the provider, but it's the providers bearing the burden of the patient's fear and anxiety, sometimes anger over the thing. And then it leads to, not always, but it leads to people starting to perhaps not take their medication, and then that leads to complications that take us to the emergency room that keep this cycle going. And the loss of trust is, I think, for us, the most painful part, because pharmacists have always been among the most trusted providers, simply because you never had to make an appointment to see your pharmacist. You never had to pay a copay to see your pharmacist. And now, we're just seeing, all of that start to really break down, and it's hard.
And I would imagine that, trust really is at the core of this, right? When you lose trust, that patients, they don't seek out care and they delay care and they end up in the emergency room. So Dr. Norton, can you talk a little bit about, we're probably all familiar with the pit, right? And the depictions of, how patients show up and maybe some of the frenetic environment that they're operating in, but also the decision and fear that they bring into that situation, that they're burdened not just with seeking the health care that they need, but the cost of that care, often delaying or foregoing care because of it. Can you talk a little bit about the patient impact?
Definitely. So the pit was very accurate. I don't know. I don't know if anybody in here has watched it, but it sounds like you have. Very accurate to how it is to practice in modern day emergency departments and how hectic it is and how many patients there are and how many patients are waiting. We're definitely overcrowded, but a lot of the reason that we have the overcrowding is because we also have a boarding issue where, it's the financial system, the way the healthcare system is so complex, and a lot of times procedures are prioritized over patients coming in through the emergency department. So they don't staff upstairs to take the admitted patients out of the ER. So that's what you're seeing in the pit as well, is that the patients are admitted and they're sitting in the ER for hours or days. So that's like one of the accuracies of that, but I'm getting off track a little bit. So the issue with patients is that they are delaying care. They're coming in much sicker. And then once they get there, they're asking about costs because they're concerned because they may not have insurance that covers enough of it, or they may not have insurance that, their deductible's too high, or they have no insurance whatsoever, and they know that they're going to go into debt just by being there. And so I have patients refuse required testing. I have patients that leave against medical advice. I have patients that, they'll refuse admission even though, they're having chest pain or something serious. I had one the other day that signed out against medical advice with chest pain, and he actually had plaque in his arteries and needed to go for a cardiac catheterization, but he decided he was going to leave against medical advice because he needed to get to work, because he needed money from his job and he couldn't afford to stay in the hospital. So the effects are that people aren't getting the preventative care because of insurance issues and cost. They're not getting access to specialists because of insurance issues and cost. They're not getting, once they get to the emergency department, they're refusing care because they can't afford it.
And can I just stay with you for a moment, Dr. Norton? Can you talk a little bit, and we can go around the panel, about moral injury and talk a little bit about how this is affecting the workforce? We've touched a little bit on it. We've talked about the trust issue, the frustration, the high cost for patients, the delaying of care. But I know there are a lot of concerns about our workforce. Can you speak a little bit to that?
Yeah, so emergency medicine's number one in burnout, so we're number one, woo! And unfortunately, I think it's somewhere upwards of like 60% of emergency physicians are burned out. And probably half of all physicians are burned out at this point. And a lot of that's post-COVID, but a lot of it is the system that we're working in. And a lot of us don't like the term burnout because it kind of places a lot of blame on us, like we're not strong enough, like we aren't resilient enough to handle the system that's crushing us. And that's not true. What's really happening is moral injury. And that's just essentially when you know what's best for the patient, but you can't provide it because of barriers from the system, or you're being told to do things that you know are wrong for the patient, like discharge a patient because they don't have insurance, which I've actually been told to do. So, things like that, it takes its toll on physicians. We see that physicians that are experiencing this are retiring early, and we already have a physician workforce shortage. We're going to be short about 86,000 physicians in the next 10 years. And that's scary because we already don't have enough access to care. So now you have physicians leaving the practice of medicine early because of the systemic pressures and the lack of financial reward. Like after you go through so many years of your life training, you come out with massive amounts of debt, and then you're put into a system where middlemen are taking all the profits off of your sweat and tears for your patients. So it's just most bright, smart kids now are not choosing medicine as a career. And that's scary too, because we want the best and the brightest to be physicians. So we're seeing attrition on one end, we're seeing less people going into the field on the other, and a lot of that is from the moral injury of it. And then we have to talk about physician suicide, because every day a physician commits suicide in this country. It's about 300 to 400 physicians a year. And so we can't afford to lose physicians. Like, we already know we have a shortage. So this is a big problem in the healthcare system. And I've lost colleagues to suicide. And it's to a breaking point. We're being put in positions where we have to watch patients choose between their health and their finances. And it's not a good place to be.
I really appreciate that detailed description of moral injury. And I think on the opposite side, we hear the same thing around patients feeling shame, right? Shame that they can't provide for their families and that they are fearful of getting the health care that they need, and denying even their own children or delaying care because of fear of cost. So I think it's really important to elevate both sides of the equation, and I appreciate the comments on burnout, because we often have that same conversation with patients and telling them, this is not your fault, right? This is not your fault. This is a broken system. So Monique, I wonder if you want to add something on sort of the moral injury issue.
Well, first of all, everything you said completely resonates. For me personally, for my pharmacists. We have a problem with pharmacists and suicide, and I think it's compounded because there's also this business ownership issue, and there's shame there. I've met, so many pharmacists who, come to my organization when they discover who we are, and they talk about, I just thought it was me. I thought I was a bad business person, and I say this, I've said this before, I will continue to say this. The level of thinking that got us here is the same level of thinking that got us into the 2008 financial crisis. This was not ever created by healthcare providers. This was created by people in back rooms who could figure out how to best maximize healthcare dollars and how they could grab and squeeze everything out of it, to the point that providers are working harder than ever to do the best they can to provide care. My son wants to be an emergency room physician, so I was listening to it, and I'm like, oh my God. We're seeing patients feeling ashamed. There's a lot of shame associated with our healthcare system, which is insane. Healthcare shouldn't be something we should be ashamed about. And until we begin to deal with that, our healthcare has become another tech platform where middlemen are taking major cuts. We will continue to be stuck in this loop.
And Dr. Adair, I'd like to close with you as we sort of wrap up the panel, if you have words to say about this issue as well.
I think Monique touched on it earlier, of the problems that we have with the system. It's the downstream effect, and it's the providers, the doctors and the dentists and the patients that are the ones that are having to deal with that. And so for example, in dentistry, we might do a procedure and then we submit to the insurance company and they come back and they say, well, this was not a necessary procedure and we're not going to pay. Or we're going to pay, but we're going to pay this small amount. And oh, by the way, if you're in network, you can't charge the patient, to help recoup the difference, and it's an extremely small amount. Or it's going to be a large out-of-pocket cost for the patient when they thought that their dental insurance or their dental benefits was going to cover it. And as a dentist, we're the ones that are on the receiving end of that anger and that frustration from the patient. And the amount of time that we are spending trying to educate and explain the process to the patient is extremely demoralizing and frustrating, and we are all really trying our best. However, the system that is within it is really against us.
So I want to thank all three of you for sharing your stories today and shining light on this important issue of corporatization of medicine, and really your commitment to the coalition and to the issue, and we can leave on a hopeful note that has power. So thank you all. And I'm going to pass along applause for our panel. And I'm going to pass the mic to Anthony Wright.
Good morning. My name is Anthony Wright. I'm the Executive Director of Families USA. the longtime nonpartisan consumer health advocacy organization fighting for 45 years for quality, affordable, and equitable health care for all. I come to this work as a longtime organizer and consumer advocate at the state level. And with many in this room, I've been proud that we have proven that progress is possible, expanding coverage for millions through Medicaid, through CHIP, through the Affordable Care Act, and through the Inflation Reduction Act. And that includes the person I'm about to introduce. And yet, with all this progress, I know that we have much more to do. Americans are angry about affordability and specifically health care costs. Health care prices aren't just high, they're inflated and irrational, with no correlation to quality or outcomes, but to market power and market failures. Research shows that the root causes of skyrocketing healthcare costs is consolidation, with large monopolistic healthcare corporations cornering key markets, buying up small practices, and then charging more because they can. And so private equity exacerbates this trend with a model geared towards short-term profit extraction rather than long-term public health. Just last month, We at Families put out an analysis that showed that a majority of hospital care across 2,800 hospitals was controlled by a handful of big corporate healthcare systems, systems that use their market power to charge nearly 3 times what Medicare pays for exactly the same service. And so that's why Families USA is proud to be among you all in joining the Break Up Big Medicine Coalition, because the big and key drivers of our healthcare affordability crisis are clear. Big hospitals, big pharma, and big insurers that our political leaders need to rein in. And so luckily we have some leaders in Congress who are also fed up. Senator Ron Wyden has long championed access to health care for our most vulnerable, protecting Medicare, fighting for children's coverage, and taking on big pharma. He's grounded in grassroots work from his Gray Panthers days, and
shady past.
He helped push through the Inflation Reduction Act across the finish line, which gave Medicare the power to negotiate lower drug prices for the first time in memory and cap out-of-pocket drug costs for seniors. We're grateful for Senator Wyden's ongoing work to cap costs. Maybe he'll make more news today. And we just thank him for his leadership in the conversation about how to chart the path forward, so that while the Congress cuts care, not costs, he's looking at how do we not just repeal and rebuild, but how do we reimagine a better healthcare system. But that starts with breaking up big medicine. So it's my absolute pleasure to welcome back to the stage the Executive Director of the American Economic Liberties Project and the great Senator from Oregon, Ron Wyden.
Thank you, Anthony. Senator, welcome. We have a packed standing room only for you over here. As you can see, there's a lot of energy to break up big medicine. So we have a lot to cover today. In 20 minutes, we're going to solve the healthcare crisis in America.
As soon as I heard that we were going to be talking about breaking up big medicine, I said, today I get to run with the right crowd.
So this is absolutely the right crowd. So at Economic Liberties, besides focusing on data, we also really ground our work in stories and in the voices of people who are working in healthcare and are impacted by healthcare. But as you know, in DC, often the conversation is about like codes and actuarial tables, but you're someone who holds a lot of town halls. So I want to just start with, what are some of the stories that are grounding your approach to healthcare and the policy ideas that you have?
Well, first of all, I think Democrats and grassroots folks who hold town meetings are on the right side of history. You may have heard the Republicans actually put out something like a decree that their members should not have town hall meetings. So you say, what are you getting an election certificate for, folks? It really drives it home. And I've had 1,167 town hall meetings in my time in the Congress, in the Senate. And let me just give a couple of quick comments about what I've seen recently. I made a tour of the rural part of the state where Donald Trump got 70% or more of the vote. I mean, an enormous, enormous vote. And they know right now, based on everything that they've been able to pick up, they are about to get hit by a wrecking ball. And they're having trouble keeping doctors. They're having trouble lining up suppliers. They're having trouble getting people credentialed. We were talking about this. And this is all because people know what's coming. And, going back to my days with the Gray Panthers, I've seen powerful people try to hide things in the past. But I've never heard of a political party like the Republicans hiding until after the election what they've really done on Medicaid. It is an astounding example of non-accountability is the only way I would describe it, and people are catching on. So I think for everybody to be out there paying attention to economic liberties, just know that this is the time for bold action. People know they are about to get shellacked, and we're going to have to get the word out, not only what they did wrong, but also some of the things that are going to make a big difference. And today, I love the fact that we're talking about economic liberties because the Republicans are taking them away, and they're using bureaucracy, they're using red tape to take away people's health care that they're eligible for. It is an astounding way to do business, but that's what they're all about.
Well, speaking of bureaucracy, and one, besides rural hospitals, pharmacists have also been really impacted by all the bureaucracy and the middlemen who layer on to them. So, and last year, or earlier this year, you spearheaded some major PBM reform in Congress. So do you want to talk about that? And also there are a bunch of other middlemen, like GPOs and wholesalers. Like, how is Congress thinking about this entire ecosystem of middlemen that need to be taken on?
Well, other than the Democrats in the Finance Committee and elsewhere, the Republicans aren't thinking about much. I mean, they're thinking about trying to figure out ways to explain what they've done because their folks at home are so angry about it. So I think that if you look at the $5 trillion that we're spending on health care every year now, clearly the middlemen are a major, particularly when you look at consolidation. The consolidation that's going on in big medicine, which you all are right to fight, that's a perfect opportunity for more opportunities for middlemen to sweep in and say somebody isn't getting results with this so-called new approach. Let me try it out with my people, and then all of a sudden they're raking in big sums.
No, absolutely. I think that one of the terms that we use at Economic Liberties is there's a lot of corporate sludge that people have to sort of get through to get the care that they need.
That's a charitable description.
You're right.
Remember, the first thing that happens is the providers who want to help their patients are given time limits. Can you believe that? Time limits, you've been trained, you hoped all your life to be able to go out and fight like hell to help your patients and get through things, and the first thing you learn about is the sludge and the time limits? I think we can do better.
Well, the Break Up Big Medicine Coalition has 22 national organizations who agree with you that, healthcare is being controlled by a small group of corporations or by private equity, and that the core problem isn't coverage rate or reimbursement rates, but it is a power issue. It's vertical integration.
Did y'all hear that a small group of doctors in Eugene, Oregon beat private equity?
Yeah, do you want to tell us more about that?
Oh, we just love it. It was small doctors, small practices beating private equity at Peace Health. They basically threw in the towel because they knew how much bad press they were getting. And you want to make some news today? I'm pitching now the effort to take what was done in Eugene, Oregon, working with you all and others, and putting it into national black letter law to protect people nationally, not just in getting the wisdom of Eugene, Oregon out.
That's incredible. You've kind of jumped ahead to my next segment.
News.
We made news. You're going to be making a lot of news here. You also are here today to announce your Medicare Cost Cap Act. So can you tell us about it and why this is so important for seniors?
I mean, the long and short of it is everybody powerful's got a cap. The employers have caps. The ACA's got cap. Medicare Advantage has got a cap. Medicare Advantage and the big insurers are using the fact they have a cap, and traditional Medicare has no cap, and folks are getting clobbered. They're using it to come up with new ways to rake in patients and get people off traditional Medicare, and it's outrageous. And traditional Medicare has always gotten the short end of the stick, and what I'm trying to do is change that. Orrin Hatch and I, before he passed, we came up with something that did make some sense to help with chronic care. It worked fine for the coordinated care programs, but traditional Medicare has been left out. So it's time to play some catch-up ball for traditional Medicare. It's about 43% of the Medicare population, and what we're doing with our cap is saying that we're going to make sure that we get a fair shake for those seniors. $5,000.
That'll be a great cap for everyone. So, I mean, there's a lot of like strong Senate support on this bill. Do you want to sort of share who else is on it? And
well, what we've tried to do in the Finance Committee is get a cross-section of political philosophies. We've got some of the most progressive senators and some of the more moderate senators, and we're just going issue by issue. We're looking at long-term care. We're looking at holding down prescription drug prices. We're trying to make insurance that works for everybody. And that's what I recommend to people, to turn this into, and that's why you've got economic liberties in the title. I suspect there's some people here who aren't blue. I suspect there are people with different political philosophies. Get them to the table and say, look, you know, we've got a chance if we come to play now to make major reforms. The country's looking for it. The country's ready. And just remember, it's not a spectator sport. I think you know that. That's why you're here when everybody else is starting to celebrate their 4th of July holiday.
Country is definitely angry. I mean, healthcare comes up as the top issue, and we did some polling, and about 72% of people across like the political spectrum support breaking up these companies. So there's definitely energy for this. But
I think that people in America today are going to bed at night worried that they are one illness from getting wiped out completely. I mean, they're just, particularly when you don't have things like a cap for 43% of the Medicare population, they can't pay those bills. We had to try to write criteria in the new bill just to make sure that they didn't have their assets taken.
So I think that's right, that a lot of people are using GoFundMe pages really to fund healthcare, and that should not be how we run the system. So there is lowering out-of-pocket costs definitely matters, but so does tackling the inflated prices that are set by these giant hospital systems and private equity-backed practices. Would you support price controls for healthcare services, sort of using the leverage that the federal government has, like it does in Medicare drug negotiation, but make that available for everyone?
I use the word caps, and I use the word marketplace power, and I looked at some of your materials, and I think those kinds of things that bring people together and show that you're using your leverage, you're using your smarts. I mean, here's Medicare with millions and millions of people, and for years, it didn't have the power to negotiate. Now, that's dopey even by Washington, D.C. standards. I mean, you just don't sit away and look at your leverage not being used. And so marketplace power, leverage, using your clout, negotiating. That's what they did in Eugene. In Eugene, they basically said, we're going to let these private equity guys from back east try to explain how this is a good deal for small doctors and practices in Lane County, Oregon, 3,000 miles away. And with your help, they won, and they won big, and that's why I'm going to try to turn it into a national law.
Now, well, more strength to your elbow to do that. I know that one other area that you are really focused on in the Finance Committee is developing policy on long-term care, and that's also another area which private equity has its tentacles in with nursing homes. Like, how are you thinking about, how does Congress go about ensuring that taxpayer dollars actually go to patients and practitioners, not these investors? Like, do you see this bill covering that too?
Well, Mehmet Oz really takes the cake. When he came for his confirmation hearing, he said, we really don't need all these bureaucratic rules and stuff because we've got algorithms. And I said, Mr. Oz, let me see if I get this straight. So you're saying that a 93-year-old woman in the middle of the night who's got to get up and go to the bathroom is going to benefit from your algorithm approach? And he went, and all of a sudden, he stopped talking about it. But I mean, the point is, they all use these, big lobbies, and this long-term care issue. I'm so glad that you'll talk about it, and if we can spend a minute or two. I was a young congressman, and I had a full head of hair and rugged good looks. And the Republicans said he's a Gray Panther. They didn't know what a Gray Panther was, but it sounded interesting. They said, help us on long-term care. And this was decades ago. And this country has been chewing for years and years on what to do about long-term care. And it's a disgrace. And so Stacy and the team are, here. Welcome good ideas from anybody, any time. But we're committed to finding a plan to make sure that every senior, every disabled person has care at home. That's one of the things we're going to say. It's time. It's time. Should have been done decades ago. And along with insurance reform, holding down prescription drugs, trying to find a comfortable place for seniors and disabled folks at home is on the ledger, and it really is decades in waiting, and it's time.
I will say that speaks to me very personally, as we were talking about earlier, with my father needing that kind of care full time. So it's wonderful that you are so focused on that. And I know that a lot of millennials who are caring for like aging parents, like this is the conversation that we're constantly having. Like, how do you make sure that there's like affordable care? Also, a lot of people are also being squeezed by childcare. And then on the other end, you have aging parents who you have to figure out how to take care of. What other like trends in healthcare are you paying attention to? Like you talked about algorithms, obviously AI is like the topic.
That's obviously a big one. And there's the patient care side on AI, and then there's the science side on AI. And the Trump people are getting it wrong on both. So we'll have some more to say about this. I mean, when everybody brings up the question of AI, and I'm going to a press conference, Chris Murphy, the senator from Connecticut, he and I are going to announce a bill in a couple of hours. I'll let him make the announcement, but we think it's time to raise the minimum wage and give people a floor of decency. And Senator Murphy deserves a lot of credit for inviting me to do this with him, and we'll be announcing that today. So we're playing catch-up ball on some of the things, and the reason I raise it right now is that all these companies are saying, look at the prospect of these layoffs, and that's why we need big economic ideas. You guys are fighting big medicine. Let's have big replacements and big ideas that talk to the question of folks having a chance to get ahead, because we know what the Republican objection is going to be to virtually all of what we're talking about is we need to have the money for the billionaires and tax breaks and all those kind of people. And we had a hearing on Social Security a couple days ago, and I pointed out, how can it be that we have two systems? If you're a nurse and an electrician, you pay taxes into Social Security, constantly. But if you're a big power player, you say to your lawyer and accountant, I don't want to pay taxes this year. I want to live off my loans and all my investments and the like, and they're able to support this double standard. So whether it's healthcare, whether it's Social Security, whether it's economics and AI, it comes back. Are we going to give everybody a good shot at getting ahead? And I talked to my friend Sherrod Brown the other day, and he said, we're all going to be joined in terms of trying to make sure there's a fair shake that gives everybody in America the chance to get ahead. That's the message I like. Give everybody in America the chance to get ahead, not just the people at the top.
Can definitely agree on that. And I think that we're going to have a talk later today on AI in healthcare. And sure, AI as technology can be used for a lot of advances, but it can also be used to just entrench the power of these big medicine companies, like, entrench that horrible bureaucracy. I can't think of anything scarier than the intersection of big tech and big AI and big medicine. So I think that that's really something that's worth, for policymakers to be focused on very quickly, because
big time. How many progressives in the room are interested in exactly what was said? Because I am. Good point.
Well, as you said, we have progressives, independents, Republicans, people from all political stripes here in the room. So, and everyone's really charged up to break up big medicine. What advice do you have to folks over here? What do you think we can get through Congress, come November?
I think that the things we're talking about now, we can pass. I mean, I think we can get a cap for folks, the 43% of the people on Medicare who deserve it and, in effect, aren't getting what everybody else in America is getting. Look, political change, particularly on health care, is not trickled down. It doesn't start here and goes this way. It's just exactly the other way. It's bottoms up. So if you have people that you're talking to, like the folks that I started with, talking about with rural, Oregon, the 70% who voted for Trump, I think they're looking for something new. And they're not particularly talking political party. They're saying, who's going to, as just mentioned was made, who's going to be willing to take on powerful people to get real change, not just change that's about a press release or something, but it's real. And I don't know if we're getting ready to wrap up, but I guess I'd like to just offer one thought for starting. I think we need to explain to people that health care is far and away the most important issue in America. Because if you and your loved ones don't have your health, everything goes by the board. We were talking a little bit earlier about parents and parents who are doctors, and all of a sudden they're faced with health care conditions and they're having trouble figuring out where to turn. So America is ready for better here. They're ready for something that's inclusive, gives everybody a fair shake at getting ahead. And the reason I wanted to come, most of Washington has left the city today, and 2 people are left. Folks like you who care about economic liberty, and a couple senators like Chris Murphy and I who want to help. Thank you.
Well, that's a great note to end on. Thank you so much, Senator.
All right. By order of the federal government, when you fix all this stuff, take the rest of the day off.
Great. Well, thank you to Senator Wyden. Actually, why don't we all does everyone want to take a minute? We've been on like a rapid fire pace. Thank you, Senator Wyden, though, and your team. I'll just say one more word, Senator Wyden, and about your team. From the minute we talked to them and said we are going to break up big medicine, they were like, we want to hear more. We want to be all in. They are not just having him here today, which we are very grateful for, but we're meeting with their team this afternoon to have more members of the coalition. Yes, so thank you. Great. Well, yeah, everybody just want to take a second. We're slightly ahead of schedule. We've been on a rapid fire pace. Don't move from the room, but just like move your body. That is what I'm saying, in place. As we transition to our next panel. And this panel is going to be led by Jean Lambrou, who is the Director of Healthcare Reform and Senior Fellow from the Century Foundation. I'll invite her and the rest of the panelists to come up. This isn't a real break. This is just a breath, not a break. Okay, thanks.
Okay. Okay.
Yes. That was rapid. I know that was rapid. We'll start at yeah. Who's chatting? Yeah, give that a second. Yeah. So let's give it a second to like my lunch and talk to him. I think that's cool. And then we'll start. So it's nice actually that we have a little bit. I mean, I think that kind of was preparing. Yeah, but I think that's I think it's cool for people to be able to, yeah. Oh, well, no, do it in front of the step and repeat it from. Oh, wait, no, we should. Katie. The only people who don't need to be in their seats right now are those who are taking a Break Up Big Medicine photo with Senator Wyden. If you're taking a Break Up Big Medicine photo with Senator Wyden, do your thing. Otherwise, time to sit down. Thank you, thank you, thank you, thank you, thank you. Jean Lambrew is going to be very angry if people don't sit down in 1 minute. Okay. We do have a really nice Break Up Big Medicine logo and sign. And so if anyone wants to do a photo, I've already posted mine. I hate the clapping thing, but if we have any traditional organizers in the room that do the clapping thing, I welcome you to do it. It's not my thing. There we go. There we go. Okay, good. Awesome. Just not into it. Really appreciate the help. Not my thing. Okay, I think we're good. Folks in the back, we're going to get going. We've got our online audience. We are a hush over the crowd, and I pass it to Jean Lambrew to enforce the beginning of our next panel.
Hello, everybody. Good morning. Good morning. Thank you all for being here. My name is Jean Lambrew. I am the Director of Healthcare Reform at the Century Foundation, and the Century Foundation is pleased to play a supporting role in this conference. So I had worked in federal government for 20-odd years, but then had the honor of being the Commissioner of Health and Human Services for the state of Maine until 2024. And in that role, I realized how much ability states have to tackle big medicine. For example, while I was Commissioner, we closed a loophole called Certificates of Public Advantage that let there be mergers that were against the public interest. Just this year, the state of Maine, the legislature in Maine, gave the state the authority to disapprove a private equity acquisition if such acquisition went against the public interest. And we've seen this type of action across the nation, including in red states like Indiana, where the governor said recently, government has to intervene because health care is run like an unregulated utility. So to discuss from the front lines these types of policy options, I am thrilled to have on the stage two champions of healthcare affordability. First, on my far left, I'll introduce Kristen Link-Young, who is Delaware's Cabinet Secretary of the Department of Health and Social Services. Prior to taking this post, she served as in the White House as the lead on health policy from 2021 to 2025, being a leader in policies such as Medicare negotiation for drug prices, the enhanced premium tax credits, and really working with the different agencies on issues of medical debt. I am also thrilled to be joined by Afton Bain, who is a Tennessee state representative since 2023. From Knoxville, she has fought for legislation on reproductive rights, tax relief, and healthcare access. She is a licensed clinical social worker, a former community organizer, and worked for Indivisible for 3 years prior to coming to these posts. Their bios are online. They have done much more than I can say in this short period of time. But I do want to get right to the heart of the matter, which is asking each of them, starting with Representative Bain, what are you working on that will get at this topic of breaking up big medicine?
Thank you. Oh, is it on? Okay. Is it on? Test. Okay, there we go. Well, first I want to thank AELP for inviting me to speak today. As the Tennessee General Assembly Research Department affectionately calls you all, left-wing New Dealers. So yes, that is an absolute yes. So for you all, my question to you all as a crowd, what does Blue Cross Blue Shield, HCA, and Farm Bureau, what do they have in common? They are headquartered in the great state of Tennessee. They also spend hundreds of thousands of dollars to a tune of millions of dollars over the past 15 years to the Republican supermajority that is now ushering in an era of Christian nationalism. Tennessee is also a mecca for regulatory capture and corporate dominance. And these policy choices allow and create exemptions for powerful healthcare companies like HCA and Blue Cross Blue Shield from the rules that everyone else has to follow with minimal accountability, and then passing those costs on to not only the patients and the consumers, but the providers as well.
And you're probably not shocked that as a member of the Democratic superminority, out of 99, we have 21, and in a totalitarian state that has very little governing power. I have very little governing power, but I am a community organizer, and I was just reminiscing that my first event with Indivisible was a training that was in this room. So this is full circle for me. 8, 9 years, I don't know, years go by during fascism. So, but I wanted to talk about Blue Cross Blue Shield in particular because I have a family, the Smith family constituent, whose son has a rare form of hemophilia. And he has a shot that he has to take that is $10,000 a week. And Blue Cross Blue Shield is trying to pass these copay, what are they called? Copay maximizer loopholes, where basically they're double dipping. And I worked with them, and it turns out that this bill was stalling in the Senate. And there was one particular Democratic Senate member who they were having a tough time with. And I was trying to understand, like, why this family is struggling. These families with medically complex kids are struggling. Why is there so much, why are we pushing her so hard? Turns out she's taken $50,000 from Blue Cross Blue Shield over her career. And so I've really worked on the patient advocacy side to try to instill some agency in these families to organize across constituencies, so cross-intersectional work. And with that, also the primary care physicians who are also dealing with AI downgrading, the AI downgrading scam from Blue Cross Blue Shield. And so I introduced those two groups with the hopes that they will work together and we can put together a break up big medicine type legislative portfolio for me to unveil next year. And then I would be remiss if I didn't talk about the pharmacy benefit manager bill that passed in Tennessee. I want to extend a big thank you to Pat and Ben Jolly with AELP. Yes, give it up. Oh my gosh, anytime I see Pat, I get so excited. Oh my gosh, and Ben's here. Oh my gosh, I'm so excited. So I wanted to take on this fight as a Democratic member of a super minority because it spoke to my issues, which are anti-consolidation, anti-monopoly, but also I got my start as a rural organizer and helped start the rural organizing program at Indivisible, and then was a political director for a group called ruralorganizing.org. And so I knew that this was, for me, a valuable vehicle to have conversations about what monopolies were in Tennessee. So I decided to record a video. I used social media to talk about and demystify issues. And I recorded this video. I forget what the title was called, but like CVS is lying to you. Oh, it's so dramatic. CVS is lying to you. And the day after I recorded that, I had a rural Republican pharmacist show up in my office. He was in the seat in front of me at 7:30. He's like, "Thank you so much for that video. I shared it. You understand. You get us." And he's going to be a lifelong Afton Bain voter for life. But that's not why we're here. More importantly, as you all know, and I told you this is my long one. I got to get through it. What was happening was CVS Health was using their marketing text messages to ask people to lobby against this bill. And so, like, I was receiving screenshots from friends that were like, "Your prescription's ready to pick up. Oh, by the way, email your representatives because it's going to close 600 pharmacies in Tennessee." So I ended up sending a letter to our Attorney General, who is a Christian nationalist, but also, is good on this issue. So, strange bedfellows. And I sent him a letter asking him to, go after CVS, inform them that the marketing did not equate to lobbying. And so his chief of staff ended up dropping the letter that they sent to the president of CVS Health the following day in my office, and those texts stopped. So that's one thing I can say I did in government.
And then turning to Secretary Link Young, you are in Delaware. Also, I should have noted, she also worked for the state of North Carolina in the past. What's going on? What are you doing? What should we look forward to?
Yeah, absolutely. So I will start by saying that it is a tough time to be leading a Medicaid and Social Services agency. Senator Wyden talked about, the cuts to Medicaid and the SNAP program that are devastating families. and that states are really in the thick of dealing with. But the bright spot in my work right now is the work that we are doing in Delaware to take a real consumer protection approach to the way we regulate our healthcare markets. And we are on the cusp of passing 3 pieces of legislation this session that are really charting a new path forward for how you put consumers and patients at the center of the way you think about your healthcare markets. And the first of those is a groundbreaking piece of legislation on hospital charity care that standardizes and makes much more universal the charity care process at all nonprofit hospitals in Delaware. So we have established strict limits in state statute that require that charity care be available well up the income spectrum. So there's access to free care below 200% of poverty, and there are graduated limits going up. And there are special exceptions for people even at higher income levels where their hospital bills constitute more than 10% of their household income. So this is a far-reaching set of charity care protections that guarantee Delawareans the protection that our nonprofit system is supposed to be providing to them. And again, they reach up well into the middle income brackets. And we do all of this in a way that also puts an onus on the hospitals to make sure the patients are aware of the charity care to which they are entitled. These are not just protections that will exist on paper, but rather we are requiring hospitals to be out there notifying patients of their rights and of their protections, which we hope will stop medical debt from accumulating in the first place. And we are so excited. This bill has now passed both chambers and is headed to the governor's desk. And we are thrilled to be, again, centering patients and putting consumer protection at the center of the way we think about our hospital market. The second piece of legislation that we are advancing this session is a hospital price cap, reference-based pricing for all of our hospitals that will structurally lower the cost of hospital care in the state over the next 6 or 7 years. And so it is not enough to protect patients from high out-of-pocket costs. We also need to make healthcare systematically more affordable. And so we are taking critical steps to use reference-based pricing, to use these price caps, to cap how much commercial health plans have to pay for hospital services in ways that we are optimistic will bring down our long-term hospital cost trends in the state. And then the third piece of legislation that we are excited to be moving out on is legislation that places a temporary moratorium on any private equity acquisition of a nonprofit hospital in the state of Delaware. We watched in Delaware as Crozier took over hospital systems in neighboring states, and we watched the fallout from that. And we said not here, and so we are advancing a piece of legislation that will temporarily place a moratorium on any private equity acquisitions in the state of our nonprofit hospitals, and we are fortunate to be a state that has a fully nonprofit system footprint, and so this is a really important start to take aim at some of the drivers of consolidation and high costs in the system.
Well, thank you both for that. And just going back to the promise, but also the challenges. I can say from my own experience, I can name as many losses as victories that we've had in the state of Maine at the federal level. We know that the healthcare industry is number 1 to 5 in terms of federal lobbying dollars spent on this. How have you taken on these challenges in trying to advance policy?
Sure. So I think 2 big challenges in this space as we try to navigate. The first is the political power of many of these institutions. At the federal level, hospital systems are often the biggest employer in almost every congressional district in the country, and so that is challenging in getting folks to really focus on reform. People are scared of changes in employment and other threats to economic development in a region, and so that makes this work really complicated. At the same time, you can break through those barriers. Reflecting on my federal experience, people said for decades that the pharmaceutical industry couldn't be broken, and then we successfully negotiated the Inflation Reduction Act, which gave Medicare the power to negotiate drug prices for the first time. And I will say Big Pharma was stunned that it happened. They'd been unwilling to engage in the legislative process. They thought they would win again, as they always had, but patients were fed up, and there were real champions in Congress, and we were able to get that done. You can break through these barriers. And in fact, all three pieces of legislation that I just talked about that we are advancing in Delaware ultimately received the support of the Delaware Hospital Association, the Delaware Healthcare Association. And we got there because we have created an environment where our hospitals understand that change is coming. And there is a sort of broad understanding in the community that the status quo is unsustainable. People are furious about what is going on. Costs are totally unsustainable for families, and something needs to change. And ultimately, we were able to channel that dissatisfaction to broker something of a peace and move forward with the support of Delaware hospitals on putting in place these key consumer protections. And our hospital association deserves a ton of credit for doing that hard work and understanding the mandate for change that so many folks are feeling. The other challenge that we face, and I think it's critical to highlight, is just the complexity of the healthcare system. Healthcare is maddeningly complex. The way dollars move through our system is infuriating and impossible to track. And so as a policymaker, you don't have a simple spigot to just turn off the bad dollars and let the good dollars keep flowing. It is hard to design policy that protects patients and centers the needs of patients and clinicians while sort of turning off the dollars that are distorting our system and enriching investors and all of that. And so being really attentive to the incentives we are creating and sophisticated about the way we design policy so that you are stopping the bad dollars while letting the good dollars continue to flow is a challenge in all of this work.
I think my biggest issue right now, as not only a legislator but as an organizer, is just the lack of radical imagination that Americans have about what is possible. I've knocked thousands of doors in the South, and when you ask a Tennessee voter to describe a world without the words premium and deductible, they can't. Right? And that's a big problem. And so in my legislation and my organizing, I'm always trying to build the muscle to radically reimagine what is possible. And then two is the regulatory capture of corporate consolidated states in Tennessee. And I want to give an example of the Farm Bureau, which you all are probably like, why the Farm Bureau? Well, when I was a baby organizer in 2017, working for the Tennessee Justice Center during the 2017 Medicaid and ACA fights, I discovered that the Farm Bureau was selling subprime plans on the ACA marketplace. How is that possible, you might ask? Well, have any of you gone to an SEC football game? Any of you gone to Neyland Stadium and watched the Vols play? It is a full-blown indoctrination, proselytizing experience for the Farm Bureau. And this is a billion-dollar business empire that their portfolio includes insurance, mutual funds, and they use their C6 status as a membership organization to execute its business activities, which is a lot of lobbying and also sabotaging the Farm Worker Modernization Act, but that's not why we're here today. And the state of Tennessee in 1993 said, well, you're a membership organization, so you're not really selling health insurance plans, which is how they get around that. And so their health plans are regulated as not insurance because they are a non-for-profit membership organization. And because of that, Tennessee has allowed them to continue to market and sell non-ACA compliant plans to individuals in Tennessee, which has absolutely tanked our market so much that Blue Cross Blue Shield a few years ago dropped like 20,000 people from the plan because they could not sustain it. And in that, with the big ugly bill, as I affectionately called it on my congressional run last year, it is a perfect storm. And I think what is so trying about this time is, as you mentioned with the Medicaid cuts, I mean, I got my start talking about Medicaid cuts and gutting of the ACA. And it's like, oh, well, now this is codified into law. Tennessee is going to be one of the states where everything is going to buckle, and it's going to buckle quickly, and it's going to hurt. And so Rebecca Soltnit writes that this is a time of great nightmares and great transformation. And so for me in Tennessee, it's really about building the imagination of my constituents and Tennesseans to believe they deserve better than the crumbs that they're getting.
Thank you. And I just want to take that point and go one step further, because one of the challenges, at least I've seen in different states, is that people get big medicine, they appreciate the problem, but they don't know how blocking a merger is going to help them pay their next medical bill. How do you effectively connect these abstract issues to the pocketbook issues of a mom going to take a kid for health care or somebody worried about going to an emergency department?
Some of you may be familiar with Ballad Health. Does that ring a bell? It should, because their CEO was indicted for Medicare fraud in Florida, and then convinced the Tennessee legislature to create a certificate, I believe it's a COPA, a certificate of public advantage. And they merged 2 rural hospitals that represent about 17 counties in upper northeast Tennessee. And I heard about this because I heard that there was a grandmother that was sleeping outside in a tent, Danny Cook, was sleeping outside in a tent because the quality of service had diminished so rapidly that her grandbaby almost died because of the staffing ratios within the hospital after they had merged. And so I drove up there. I interviewed tons of people who lived up in upper northeast Tennessee. And so they really can feel this. And I think they are, no offense to you all because you're in D.C., but oftentimes D.C. consultants think that voters are stupid, right? And they're not. These people are hurt. They understand what they are seeing in front of them, which that they are struggling. Their hospital is not working, right? And so in that, I think I've learned a lot as to how to talk about mergers, consolidation, in a way that people understand. And so that's also, I think, a large part of my portfolio is undoing a lot of that consolidation that exists right now in Tennessee.
I would add to that, families and stakeholders across the country are struggling right now. Family health insurance premiums are $27,000 a year. That is about a third of median income, household income in this country that is going to health insurance premiums. People's paychecks, employers' entire revenue cycles are being disrupted by the extremely high cost of healthcare, and people feel it in really intense and personal ways, even before they have an encounter with the healthcare system. And then when they have an encounter with the healthcare system, they are expecting and familiar with their friends' stories of unexpected bills showing up and impossibly high costs that folks are forced to navigate. And so the salience of high healthcare costs is really high for families, but also for employers and people outside of the healthcare ecosystem who aren't making money off of the extraordinarily high costs that we face right now. Everyone is aware of how significant this issue is, and people get it and they feel it, and they are sophisticated about the need for change and the importance of taking on this system and driving change in the way that dollars move through the system and the way that patients experience it.
And if you don't mind my following up on that question about employers, I mean, that's always a question I think we all have, which is, where are they? Why are they not as engaged, given the fact that employer-sponsored insurance remains the primary form of health insurance in this country? And I was just curious about how you've approached it. I'll do one aside before I turn it to you all to answer it. Going back to Indiana for a second, the person who has the job that Secretary Young has right now,
Gloria, she's fantastic.
Yes, she was the former head of the business group on health in Indiana, so came at this with knowing the CEOs, knowing the employers, and would bring them into the legislators to talk about it. But is that a gap? Is that an opportunity? When we're thinking about organizing, should we be thinking about employers as well? Christine?
Yeah, absolutely. I think this is critical. We in the public imagination, there are bad guys in the insurance industry, and there are bad guys in the pharmaceutical industry, and helping everyone understand that there are bad guys in a lot of other places too, and that change is needed more broadly is critical. And one of the challenges that you have in mobilizing employers is that health benefits are often are eating up revenue every single day, but they are not being dealt with and managed from the C-suite of most organizations. They are just it is a problem that is over there and is sitting someplace. And so mobilizing those constituencies and helping them understand that reform helps them is challenging. I do think we are at a little bit of an inflection point on this as costs rise rapidly and as healthcare affordability becomes such a salient issue in consumer sentiment and in the way people are experiencing the system. But there is absolutely a lot of education that is needed, and there is work to do to motivate those voices to be at the table in these conversations.
Yeah, just quickly, I mean, if you are an employer in the United States of America, you should be advocating for single-payer healthcare, period, end of statement. And right now, Tennessee, and I'm sure you all feel it, but the economic conditions in this country are going to deteriorate. I don't know what the Great Depression is going to look like, but it's happening in Tennessee, and I already see small businesses going under. And when they come to me as to how can we eliminate cost and or advocate, and it's well, I need you to be in favor of this policy, and I need you all to be pushing it at a state level. And so what my hope is the next few years that a lot of the small business owners that I represent in downtown Nashville, which are just going under left and right. I mean, I hear a new business going under or small business going under every day, that I can have an organized constituency that can help me advocate for a single payer plan at the state level in the next few years.
I do want to do a quick apology to the small business majority, who I know has been a true champion for a lot of these issues. They're here today, and I thank them for their work. It's just where are the bigger groups, where are the larger groups? And I will just go back to a point that Kristen made earlier. In most states, the health system is the largest employer, and it becomes a challenging situation when many of the state legislators are on the board of their local hospital or are close to them. And that leads to my next question, which is, I really appreciated the panel talking about the challenges that providers face in this area. But in many situations, the CEOs of these organizations are healthcare providers. They're doctors. They're coming from the field. They speak the talk. And at least in the advocacy I've seen, it has been you can't do a moratorium on private equity, because then the rural hospitals that need funding to support their electronic health records or their capital improvements can't get it. We've had actual provider groups say, I can't survive without this. And I wasn't sure if you have any tips or suggestions or thoughts on how to separate out, again, looking at our panel of providers, the people who are suffering from the kind of corporatization of healthcare from those that don't see alternatives. And I don't know, Kristen, do you want to start with that one?
Yeah, absolutely. At a fundamental level where we need to evolve as a country is that the actors in the healthcare ecosystem need to become better at taking the dollars that they get from all of us and turning that into actual health and wellness. We need to create a set of incentives that are just better at using the enormous investment that we put into the healthcare ecosystem and producing outcomes, producing cancer treatment that helps people live longer and healthier, at producing the home and community-based services that keep people in their homes and help them age with dignity, at producing effective care management. We need to be fundamentally more efficient at using the dollars, so that instead of creating a system where everyone inside of it, providers, payers, everyone around, is trying to maximize the amount of the enormous pie that they get. Those are the incentives that everyone faces today. How do we grab more of the pie and keep more of the pie in our part of the system as compared to other parts of the system? And that needs to change. People need to face incentives to do do more health with the resources that we actually give to folks. And those system design issues are, I think, incredibly important. For me, and in Delaware, that means a lot of thinking about issues around global budgeting and moving away from a fee-for-service system that rewards more and more and more rather than holistic, person-centered population health. And really thinking about those incentives. But it is a journey, and it is one that requires people to stop fighting with each other for this enormous pot of resources and instead learn how to be more efficient in using the dollars that they get.
I want to serve as the incestuous relationship between legislators and big medicine. I mean, HCA is a company that strategically places legislators who are going to be the most vocal, baiting them to serve on boards of local hospitals, right? And I think that is a strategic decision from these major companies that they are not only bankrolling these caucuses and these legislators, but it is an incestuous relationship that needs to be resolved. And so, my kind of panacea in all this is maybe not on your end, but on my end is banning political money spending, corporate spending in politics. And so shout out to any of you who are from Hawaii, because we're hoping to file that bill to basically ban Citizens United at a state level to ensure that big medicine can't be spending money and bankrolling these leadership PACs and these legislators and, giving them private seats at the Titans games, right? And so I just wanted to highlight that there is an incestuous relationship between those in office and big medicine that needs to be dissolved.
Yep. I think we all have experienced that. But as my last question, as we turn to the next panel, what about working at the state level gives you hope, feels different than what happens in Washington, that gives this audience some place to look? So we'd love to give your hopeful outlook for what's going on at the state level.
You can start.
Yeah, I mean, I need to start where I started, which is things are hard right now. There is a lot of challenge coming from the national political climate and legislation that President Trump has forced upon states. But the great thing about state government and the work that the Meyer administration is doing is that we are so close to people. I receive emails. I received one just this morning from folks who are experiencing challenges navigating their SNAP benefits, and I can fix that. We are so close to the service delivery, and we are so close to the human beings that are inside the system, and so that is energizing, and it breeds creativity because our state legislatures are also close to the human beings who are affected, and so I'm incredibly excited about the agenda that we are driving, and I'm really proud of the partnerships that we have been able to build to do it and to engage around this work. There are great ideas happening in states across the country, and they are not all in blue states. Jean mentioned the incredible work being done in Indiana, which is moving out on a lot of the same issues that we are advancing in Delaware. There are pockets of really interesting reform happening everywhere where you get sort of the mix of a public that is fed up and a set of policymakers in the state that want to take something on and that really can create models for broader change and for sustainable ideas that ultimately have a national future.
I'll answer this from an organizing perspective. I think in the next decade, criminalization and poverty are going to cross every single person's threshold in the domestic threshold in this country. And so this has been, I think the PBM fight was revelatory in that it surfaced a rabid, radicalized rural constituency that echoes, some type of agrarian populism, which I was really excited about. And so how do we continue that level of momentum and build the cross-constituency coalition I need to actually pass reforms in the state and or to build my bigger and better coalition with those from the other side who want to see reforms. And so I do think things are going to be really tough in states like Tennessee, especially with the Medicaid cuts actualizing in 2027, next year, right? yeah, it's going to be really dark, but I do believe in my heart of hearts that the most transformative change will come from the South, because as W.E. Du Bois once said, as goes the South, so goes the nation.
And I will say one more thing from my own perspective at the state level. So one thing that people fail to realize in D.C. is states are the boots on the ground, right? Like, states are the ones who go into every facility, nursing home or hospital, to certify them. They often have certificate of need or some sort of licensure programs, as well as professional licensure. So all the people who do the actual work of a lot of health policy are in the state level, which I think, flip it around, means that there's a lot of people who get it at the state level. What is actually happening? Why is it happening? What should be happening? So I think that's one factor that gives me kind of hope that states will have a major role. The second thing is medical debt, and I thank all the people who've worked on medical debt, has been sort of the action-forcing event. I think it's going to get at the root causes, but at least in Maine, every single year we pass some additional improvement to protect people from medical debt. To me, that is, again, a hopeful sign. I think it's bipartisan as well, not just in the blue states. A third thing is I do think that with the real focus on rural healthcare these days, with our hospitals, with what's going to happen with H.R. 1 in the coming years, state officials are thinking differently about what their role is in capital formation and capital development and in support for these facilities. Can they be doing what private equity have been doing in the past? Like, is there a role for government in this area? I know we'll talk about ideas later on. I think some of the ideas that you'll hear about today are like that. But I do think there's kind of a cutting edge that can happen at the state level. And just lastly, I hope that what we see as progress at the state level gives federal policy makers some of that, I think what you called it, radical imagination, because I do think it's coming time. A poll that we put out at Century Foundation yesterday said that people want radical change. We need radical change, and I'm hoping that state examples can help lead the way. So with that, join me in thanking my two panelists for their remarks.
Great. Well, thank you so much to Jean and the entire panel, Rep. Bain and Secretary Link Young. We really appreciate it. And we're going to do a little bit of a deeper dive on hospitals. Hospitals came up quite a bit in that panel and has throughout the day. But first, I'll introduce myself more formally than just corralling everyone to sit down. I'm Morgan Harper. I'm Director of Policy and Advocacy at the American Economic Liberties Project. And I have the honor of spending a little bit of time to walk you all through the members of this coalition that you've heard about throughout the day, the Break Up Big Medicine Coalition. So lots of logos on the screen, but I'm actually going to say each name, and then if there are not a lot of our folks are working healthcare professionals, so we're not necessarily able to make it here in person, but many of them were able to make it work with their schedule. So if you're part of the coalition and you are here in person, we'd love for you to stand up so folks can know who to talk to in the room. All right, first up, Alliance for Independent Dentists. Yes! Our dentists are here. You've actually already heard from Dr. Adair. American Academy of Emergency Medicine, we heard from Dr. Norton. ALP, that one's obvious. No excitement there. Okay, American Pharmacies. I don't know if we have anyone in person on that one. Yes. Oh, yeah, that's right. New position for Randy. Association for Independent Medicine. I think Jack was supposed to be here. I don't know if he... Okay, we still get a clap even if they don't stand up. We'll still clap. Center for Economic and Policy Research. This Center for Health and Democracy. Yes! Wendell and Will are here. Coalition for Patient-Centered Care. They have a lot of people. Yeah, a lot of double dipping on CPCC, but we still love them. Okay, Diadem Advisory. Families USA. You heard from Anthony and his team. The Free Market Medical Association. And I will say, because it came up in the panel, the role of employers. We do have several employer groups in addition to Small Business Majority. Free Market Medical Association kind of rose out of employers, especially big employers that were frustrated with the costs of care and figuring it out for themselves how to take on big medicine. So weren't able to make it in person, but great group and also very ideologically diverse in its representation. Groundwork Action. I think I saw some folks from Groundwork here. Initiative for Medicine Access and Knowledge, IMAC. I don't know if Tahir's already made it. Mainstream Compete Coalition, another small business employer group. National Nurses United, NNU's been a longtime partner. We're very happy to have them. You'll be hearing from one of their members later. Pharmacists United for Truth and Transparency. You heard from Monique already at PUT. Physicians Against Drug Shortages. I saw a representative earlier. Great, yep. Private Equity Stakeholder Project. I don't know if they're here. Psychotherapy Action Network. I know she wasn't able to make it, but yeah, talking about AI. That's a group to talk to if you want to hear more about how AI is playing out in healthcare, but we'll get to that later. Searchlight Investigative Journalism Foundation, Tom Mueller's group, doing a lot in like big medicine dialysis, big dialysis. We already mentioned Small Business Majority. The Patients Union. Yes, you'll be hearing from some folks from there later. UFCW 3000, really happy to have them. And we'll be on the next panel that I'll be moderating. And then our co-host, the Century Foundation, keeping us on our toes, joining today our coalition to break up big medicine, the Century Foundation. We love them, and Jean, who is part of that. And then last but not least, Write-Off Warrior, and that'll be a great time to transition to Mark Craig, who's the founder and CEO of that, who will introduce the next panel that I'll be moderating. Thank you.
Thank you, Morgan. A few years back, I was driving through Glenwood, Georgia, expecting to see the same friendly, vibrant town that I remembered. But instead, I found an apocalyptic scene. All the storefronts were shut, boarded up. Then I saw the hospital that had blacked out windows and grass growing through the cracks of the parking lot. So the hospital wasn't just any building, it was the heartbeat of the community. And when it died, so did everything else. I'm Mark Craig. I've spent more than 20 years in revenue cycle management, which is the financial obstacle course created by big insurers designed to suffocate independent hospitals and providers. But seeing Glenwood that day, I could no longer sit on the sidelines. So I created the Write-Off Warrior to fight for independent hospitals and providers, and for our clinicians and communities that big medicine has written off like they didn't matter. Our independent regional hospitals are not failing because of lack of medicine. They're failing because big medicine has them in a vice. On the cost side, we talked about the physician shortage, but it's even worse in our rural areas. They pay more to recruit and staff their nurses and doctors. And they pay more for the same box of gloves because group purchasing deals are designed for large health systems, not them. And they're reimbursed significantly less for the same services that are provided by big health systems, which is absolutely squeezing them on both ends. And because of this, they're left with few options. One, they close like what happened in Glenwood, or they cut essential services that their community needs. Or they may sell to a big health system that keeps the sign on the door, but runs it as a glorified Band-Aid station, cutting even more services. And we're seeing maternity units across the country close, turning entire regions into OB deserts, which is forcing mothers to drive hours for care in a country that already has the highest maternal mortality rate in the developed world. So that's why I'm proud to stand with this coalition to help save communities like Glenwood and also to help protect access for all patients. And there's another alarming trend. Congresswoman Mary Gay Scanlon helped introduce Take Back Our Hospitals Act, a bill that would get private equity out of our hospitals. Because we've seen what happens when private equity buys a struggling hospital and then strips it for their own profit. Crozier Health, we saw earlier, was a cautionary tale, but this is happening in communities across the country. So I'll let our panel dive into it. Morgan, I'll hand it to you.
Good. Thank you, Mark. Really appreciate that introduction. And yes, as you see, our panel is titled Taking on Big Medicine Hospitals. Very honored to have Rep. Mary Gay Scanlon here, who has joined us, and also Haley Sweet, who's a member of UFCW 3000, like I said, one of our Break Up Big Medicine Coalition members. So if you ladies will allow, I'm going to skip the deep introductions, but I think folks are familiar with you both and can look it up, and we we will tell our story now. So that's actually where I kind of want to start, is to hear actually, Haley, from you, because we started the day with hearing from some practitioners and clinicians about the harms of big medicine. And so I want to hear your perspective. I mean, you are a working RN, and tell us a little bit about your experience in that and how you're seeing this play out in the hospitals that you're in.
Yeah, absolutely. I've been a nurse for about 8 years at Providence St. Peter Hospital. If you don't know Providence, Providence is one of the 6 largest healthcare systems in the U.S. They brought in about $30 billion in revenue last year. I've worked there in a neurology unit the last 8 years, and something has felt wrong. Things have been slowly getting worse. Our supplies are lower quality, staff is being reduced, and we're just slowly losing resources to our community. I work with stroke patients, and there is a vulnerability to being independent one day and the next not able to move the whole side of your body, not able to go to the restroom by yourself, not able to communicate your needs, in severe cases, not able to understand what people are saying to you. And we have less and less time to spend with these patients than we did before. The nurses who trained me like to say the patients that are on our unit, our step-down unit, would have been in the CCU when they were trained, and the patients who are in the CCU would have been dead. We have had amazing breakthroughs in technology, but our staffing is not keeping up, and our regulation of our healthcare companies is not either.
And Rep. Scanlon, as Mark mentioned, and thank you for that, Haley. Actually, before I get to that, I do want to comment, because I think both from what you just said and what we heard this morning, and also in the video, I don't know if everyone was here the entire time, but we had a video from More Perfect Union that was an accounting of some of these harms. I mean, it's just that having to be there as a caretaker, as a healthcare clinician, and not being able to provide the care that you need or see people that can't get that. And that we just have to continue to bring attention, because I'm not sure if you aren't working in healthcare that you really know what that experience is like. So I do appreciate that. And Rep. Scanlon, I am wondering how you're hearing this play out in your district. Represent Pennsylvania's 5th, and kind of like what prompted you to take more of a look here.
Sure. So I represent Philadelphia and some of the surrounding counties in Delaware County, which forms the basis for my district. A couple years before I came into office, the longstanding nonprofit health system was purchased by a private equity firm. So the health system owned 4 hospitals across the county, serving about 500,000 people. We hear a lot about rural hospitals running into trouble, but our frontline hospitals in our urban areas are also really, really stressed. I know one of the issues here is big medicine, but it's also the failure of the federal government to have a functioning healthcare system that reimburses systems for the expenses of providing healthcare. And when you have healthcare systems that are so dependent on Medicaid dollars or Medicare dollars, then you end up with stressed health systems looking for solutions. And there was a period in time when a private equity solution could seem attractive. I think the examples have now shown that it's not. So the Hahnemann healthcare system in Philadelphia had been gutted a few years before the Crozier healthcare system was purchased in Delaware County. And what we saw was over the course of 9 years, I guess, they took everything out of the system, the classic selling off the property and then forcing the healthcare system to rent it back. The system couldn't survive. The 4 hospitals were closed. We now have a maternal health care desert in Delaware County. And the whole system went bankrupt about 2 years ago. So when I came into office, I was able to join with Katie Porter in California, Rosa DeLauro up in Connecticut to try to start investigations of the private equity firm that had taken over hospitals in all 3 of our districts. We were not able to get that to move quickly enough to save my healthcare system, but it certainly prompted the reason why we need to use whatever federal levers we can to prevent private equity. I mean, profit should not be the dominant motive in a healthcare system. So we do have a bill now, Take Back Our Hospitals, to prevent private equity ownership of hospitals and nursing homes.
And we're going to talk more about that. And just a quick follow-up, because, again, I mean, another theme we're hearing, I think from a lot of members, a lot of your fellow caucus members, too, both Congressional Progressive Caucus and broader Democratic Caucus, are starting to begin dockets, kind of like informal ways of gathering information from their constituents. So I guess as a follow-up to that, have you also seen organizing happen? Are you seeing doctors specifically speaking out? What are kind of the mechanisms that you're hearing from some folks in your district?
Folks in my district are not shy. I think probably...
They reach out a lot?
Yes, they do. I think the nurses have been the biggest force. I mean, when the Crozier system closed, 2,600 folks were laid off. The PASNAP, Pennsylvania Nurses Association, has been at the forefront of trying to keep it open and bringing attention to the harms that have occurred. But we get it everywhere. There actually was a protest in the district Tuesday talking about the need to backfill what is now a healthcare desert, looking at whatever solutions can be provided. There are investors looking at the former buildings of this healthcare system, but very unclear what way they'll go, and the concern that they're not going to provide a full range of healthcare services. But Tuesday there was a big rally around the issue with a push for community-based, community-driven healthcare and transparency. I mean, those seem to be the two big levers that we're looking for. I also hear it in town halls. So I had a town hall at a senior center probably 6 weeks ago where a gentleman in the back got up and talked about his concerns. I mean, he was there with an oxygen tank and a walker unit. And he said, I used to go to the hospital, the remaining hospital right down the road, but the lines are so long now because of, everything that's gone on, the lack of services. So instead, when he has a problem, he is driving over an hour to an adjoining state to get health care, which, poses risks there as well, and then has the added problems of trying to do cross-state reimbursement. So clearly we're not in a good place, and we need more solutions.
Makes little sense and a lot of burden on an individual. Yeah. Well, and so we are the last panel before the coffee break, which I think is both like a point of privilege and stress, and a lot of pressure on us to make this panel worth people and standing between a break. But Haley, after that, we're going to be hearing from a lot of folks about solutions. A lot of the first part of this day has been about the problems. So kind of like teeing that up a little bit too, from your perspective, like what are some of the specific problems you would point to in terms of like how this big medicine issue is playing out and driving it?
Absolutely. And I really appreciate you saying community-based healthcare, because we're in a system right now where hospitals and these hospital systems are choosing which services are profitable. Those are the ones they invest in. Those are the ones they keep open, right? In my community, we recently closed, in the last few years, Providence Neurosurgery Clinic, because we had a private clinic in town who could take those patients. Similar with our outpatient services, right? Our therapies, our physical therapies, our occupational therapies, things that get people functional and independent again. My patients have told me we did not have enough therapies in town to take up that work. So you have delays in improvement for these patients. You have reduced quality of life. And inside the hospital, we see a focus on throughput. My community has needed more beds for a long time, about a decade at least. And that certificate of need has gone back and forth, but they have had it, but they have not released the funds to build what would be another tower to our facility. Oftentimes, we have as many as 76 patients in our emergency department. We consider it a crisis if we have more than 20 people boarding. People should not be boarding in the ED. Our emergency room physicians and nurses should be caring for them, stabilizing them, and then sending them to me inpatient. But this whole process is rushed, right? Folks, it's hurry up and wait. You stay in the ED, and then once you're upstairs with me in the inpatient units, it's throughput, it's length of stay, it's how fast can we get people out of here, whether they feel ready or not. Part of my work is being a discharge nurse, and as we focus on this throughput factor, we miss the human factor of whether they're ready to go home, whether home health will be set up, We have more joint ventures now with private home health companies as we're moving away from our Providence home health company. So even though we act as we are a nonprofit, we don't always act like that as we take on more partnerships with private equity. So I think this focus on throughput is really risking people's health, especially as you look at Providence being one of the main family medicine primary care providers in the region. I myself am seen by Providence doctors, and it takes 3 to 6 months for me to get a PCP appointment. And these are the patients that I am sending back out into the community with new problems like atrial fibrillation, blood pressure problems that they need regulated, or they'll come back to me with another stroke and perhaps a lifelong disability.
Well, and I think that's so important to note, because one of the arguments we typically hear to justify the existence of a lot of big medicine entities is, oh, but it's so efficient. Or that has been part of the theory underlying allowing a lot of this. And so, yeah, you're waiting, you're not actually able to treat patients in a way that's, if efficiency is defined by good care, and actually quite the opposite. So,
what is the benefit to our patients in that situation? What benefit are you providing the community if you can't actually truly care for them in the way they need to be cared for?
Exactly. And Rep. Scanlon, so coming back to your bill, I would love to hear more about the process for deciding to do legislation specifically focused on the private equity and hospital issue that we've been discussing.
Sure. Well, I mean, it's been a little frustrating because it's slamming the barn door after the horse is out in my community, but obviously it's something that's escalating around the country, and we're looking for federal levers that we could try to push. So the bill relies upon not allowing payments of federal healthcare dollars, Medicare dollars, et cetera, to go to private equity-owned institutions, while having a transition time to allow for institutions to catch up as necessary. But you're touching on so many issues. I mean, I'm always looking for the federal angle because that's the position I'm in. So talking about the doctor shortages, that's in part a function of breakdown in our immigration system. We've actually held hearings on the fact that we need more doctors. We need to retain doctors who are studying from overseas and give them a path to continue practicing in the U.S. That's something that we have not been able to get movement on, particularly under this administration. All of the funding issues and the death by 1,000 cuts to the Affordable Care Act are obviously escalating this, as we see hospitals that were already stressed by inadequate reimbursement. Then we see things like last summer's bill that is cutting folks who are on Medicaid from actually being able to remain eligible for Medicaid because of paperwork requirements as opposed to work requirements. The failure to reauthorize the extended tax credits. Clearly the federal government needs to do a better job of making sure that healthcare is available to everyone, whatever form that's going to take. And I think these efforts to keep cutting it back are going to rebound in having a more complete overhaul.
And on the act itself, the Take Back Our Hospitals Act, because we've heard also, and actually in the prior panel, about the role of big medicine in lobbying and politics and kind of blocking reform. So has there been a strong reaction in response to the bill, or can you talk a little bit about how you navigate those waters?
I think we just saw that the need was there, and obviously it's not just hospitals and nursing homes, but we're seeing takeover of huge swaths of our medical community, whether it's orthopedists or whatever, using the same tactics, saying, oh, we'll help you out, we'll invest in you, we will handle all those annoying administrative costs that you didn't get into medicine to take care of, but then people getting squeezed out. So our focus has been, what can we do to make the system better?
Regardless of lobbying attempts to try to squash momentum on it.
That's not why I'm there.
Makes sense. And so, Haley, I know that you mentioned your structure might be a little different than the hospital you're working in terms of the role of PE, but thoughts on Take Back Our Hospitals Act, the approach it's taking, and then also other solutions that UFCW 3000 is thinking about that could address what's happening.
Absolutely. I mean, it's one of those things where I'm so sorry this happened for your district, but also in medicine we look at sentinel events, right? We look at events where harm is done, and we look at ways to prevent them in the future. So I am so glad we have those warning signs to look at in our own community, and this could protect, as funding gets more difficult, my community from getting sold to private equity further than we already have been. We would also like the Attorney General in our state to look at Providence's monopoly. Per Kaiser Family Foundation, 81% of the market is dominated by Providence. There's so much to be done there, but really just looking at the structure of our healthcare and making sure that people can maintain access.
If I can just add to that, that was another tool that we were trying to employ under the prior administration, which is using the FTC, antitrust law, to try to prevent consolidation of hospitals, et cetera. And obviously that's not as open an avenue at present, but both preventing the harm and then figuring out what are the incentives to promote community-based healthcare to, try to level up the playing field.
Oh, absolutely. In the case of Providence, in 2025, they invested $150 million for the next 10 years into a venture capitalist fund, right? That is money that could be going right back into our community, but it simply is not in the current structure. And there is no incentive, there is no regulation to keep them from doing that.
And so, last question, because unfortunately, I have many more, but we have coffee break. We can't possibly stop talking. There's coffee. Okay. So getting back to one theme that came up actually in our Executive Director, Nidhi Hegde's remarks to start the day. Like I said, we're going to hear about solutions later. We've heard about solutions, actually my entire policy and organizing life, I would say, which now is hitting 20 years or so. None of these solutions matter unless they move, right? A bill is great, but laws are better, and even when they're enforced, even better, right? So what's it going to take to get there? And I'm curious, and I'll start with Rep. Scanlon on, you've referenced a little bit of the environment inside in Congress, the federal environment. Are you optimistic about the next few years, seeing the kind of radically imagination in healthcare policymaking?
Well, I think we're being forced towards it. I mean, obviously, 2010, whatever, the Affordable Care Act, that was a long-standing reimagination, which has been eaten away at. But as I suggested, I think that there have been so many incursions into availability, accessibility, affordability of healthcare that it is going to drive us toward that. That may not be the intent of the folks who are, trying to cut back. But we are seeing, I think, Americans getting fed up with it, particularly as their insurance bills hit, as people get cut. I mean, when we have Marjorie Taylor Greene saying her kids' healthcare bills are too high, her kids' insurance bills are too high, that portends a sea change.
We hope. I mean, I think just one follow-up quickly there in a whole different policy area. We saw yesterday with the housing bill, kind of like the housing policy, the biggest housing policy that's happened in 30 years out of Congress, and then a reaction that we're going to try to delay or pause. I think it will still be implemented even. But, I think these are the things that really do brew a skepticism that even with the strained beds fellows, even with a great coalition, that it can happen. So just curious if that had any other...
Well, I think we also heard a quote from the president after he refused to sign the housing bill that had passed with overwhelming support, that he really didn't give us something or other about housing. We need people in elected office who do give a shit about housing and give a shit about health care and everything else. So that's the way forward.
And Haley, you get to close this out. So, but I have a little bit of a build up to the question though, because we're going to hear later from some of our coalition members, Century Foundation, actually to end the whole day, Patients Union, about what it'll take to mobilize the public, to elect the elected officials that actually care, to create that political pressure, to make sure it's not just talk, that real change happens, laws are enacted and enforced. And so from the UFCW 3000 perspective, how's that playing out for you in mobilizing your members and the broader public in Washington?
Yeah, absolutely. We have a lot of momentum right now. I think as our providers spoke to beautifully, we're tired in healthcare. There is too much work to be done, and we're not doing it well enough to find satisfaction in our jobs. And I think in healthcare, you try so hard to lean in and make impossible situations work, but there comes a time where you can't do that anymore. And when you can't do that anymore, you need to be honest with the communities. Our system has been really good about using that narrative to stop providers and nurses and every caregiver in our hospital from speaking out. Because you feel shame for not being able to provide the level of care that you want to provide. But we are at a breaking point now where we have to say it, and people are coming behind it. In my state, we have staffing laws, and we're trying to bring attention to the fact that the people who are making the decisions should be the people in the community. They shouldn't be a chief nursing officer in the southwest region for the South Puget Sound who doesn't know how our laws work. So if we can educate our members in UFCW, and it's not hard in healthcare, and I think in every industry, people know what they know their field, and just bringing them to the table, bringing that to the forefront, and being honest about these challenges, telling our communities we want to do a good job, we want to give you the care you deserve, we don't have the resources, and that is a byproduct of the system, and you deserve better.
We all do, period. Okay, well, thank you so much to Rep. Scanlon, Haley, especially traveling so far to be with us. Really appreciate it. And thanks, everybody. Thank you. So we have a coffee break, as promised, and we will be back in about 15 minutes. Thank you.
There's no way patients would know.
When you really look at the
people have been harmed, and they can't believe that insurance companies are acting this way.
when we could no longer actually take care of the patients the way we would want our grandmothers treated, that's when we started having problems.
There's not a sign on the front door that says that, like, ground floor front door ER is now owned by Sound Physicians Incorporated, an outside investor-owned corporate entity. There's no way patients would know.
When you really look at the board and realize there's people waiting for 15 hours and we could have had a better patient outcome if they had been seen in 6 hours, that's really hard to deal with at the end of the day, knowing you're not actually doing your best.
A woman came in her vehicle, screeching her brakes right behind the press conference, screaming at the crowd for us to help her with her baby who needed care.
They just called and said that she wasn't breathing, and my heart just dropped.
The fact that investors or companies are coming into this place that is just for patients, right? It's just for people who are in trouble or are scared or are dying. To come into that space and to say, how can we make money here, feels to me unholy.
We are absolutely at an inflection point in this country when it comes to the corporatization of healthcare, without a doubt in my mind. There is a fundamental tension between a clinician who took an oath to serve the interests of their patients and fiduciary responsibility of a corporation or private equity firm who has a duty to their shareholders to maximize their profit.
No mother should have to drive up and hope that there's someone there to save their child and frantically hand their baby who's not breathing over to someone to save when there's a hospital right here and it's empty. They came to Chester with this one intention in mind, was to take every bit of equity from us and to leave us bankrupt and to walk away.
Team Health is a private equity-backed firm that places emergency physicians at hospitals across the country. The company is owned by the healthcare giant Optum Health and the PE firm Summit Partners.
They're not usually in it for the long term. They're not thinking about how do we improve this business long term. They think about how do we make things look better on the short term so we can sell it to somebody else.
Say we're going to innovate. Well, they innovate how to make more money for themselves. They don't really innovate anything that's actually helping with society because their secret sauce is gouging patients.
A hospital is where people go for care, and a hospital is where people go to be cured and to be saved. And to think that a company can come in and treat us like any other kind of business, that when you're done with us, throw us away. They have left people devastated. People have died. People will continue to die. They sold out this poor community for money. And that's something that I think can never happen again.
Alrighty, folks, if you could please take your seats. Please get your coffee, take your seats. We're going to get rolling.
Okay, we're back. If everybody could come back to their seats. This is actually this is low, but we're going to go ahead and get started after our coffee break. And it's going to be a blitz. It's going to be a blitz. So I would find a comfortable spot now. These folks standing in the background. That's not where you want to be. You want to be comfortable and seated because we're going to have rapid fire solutions coming up very soon here. Okay, I think we're good. So again, I'm Morgan. I'm from the American Economic Liberties Project. And to kick off the second part of our half day together to break up big medicine, we are going to hear remarks from Senator Elizabeth Warren, who wasn't able to join us in person, unfortunately, but has been a real leader in this fight to break up big medicine. And you'll hear more from her all about that with this brief video that she sent in her absence. Thank you.
ELP and the Century Foundation. It is so good to join you virtually today to talk about breaking up big medicine. Woohoo! Now, you all know this, but I want to start by naming the problem. Giant corporations like CVS and Cigna and United Health have just gobbled up every part of the healthcare supply chain. Your pharmacy, your doctor, your insurance company, your pharmacy benefit manager, and it allows them to jack up prices and to steer more money to the companies that they own. This trick lets them charge more for every doctor's visit, every procedure, and every prescription, all while you face more paperwork, more denials, and worse health care. And it's not just patients and taxpayers who suffer. Independent doctors, pharmacists, dentists, and lots of other healthcare workers just can't compete. In fact, since 2019, nearly 4,000 independent pharmacies have just shut down, and almost 80% of physicians now work for a corporate parent. Now, that is the reason why Senator Josh Hawley and I introduced the Break Up Big Medicine Act to end the stranglehold that these corporate giants have over our broken healthcare system. It's a bold proposal, but it is exactly what we need to unrig our economy. And now comes the really hard part, getting everyone in the fight and passing the Break Up Big Medicine Act into law. This is a righteous fight. And when things get hard, you only have one option, and that is to persist. I am so glad that all of you here today are in this fight. We need you.
Who is Senior Director at AI Now. Our goal is to talk to you about AI in healthcare, how you can distinguish between what's hype and what's real, and the policy conditions that are necessary for AI to actually be helpful for patients and providers. So to start off, Kate, how do we tell what's hype and what's real?
Totally. So I think it's actually a good entry point to talk about what we're talking about when we're talking about AI. Because AI is a very broad umbrella term. There are a lot of different technologies under that umbrella. And a lot of these have been around for a while. Deep learning architectures, machine learning algorithms have been contributing to healthcare for decades and are. This is like what we're seeing about early cancer detection and prediction tools. Or drug repurposing, which we see a lot in the headlines, which is where you can use algorithms in order to take medicines and apply them to new rare use cases. This is very different from what we're seeing about hype from AI firms. So basically, overstated claims coming from AI firms are predicated on the idea of artificial general intelligence or superintelligence. This is the idea that AI is going to surpass our human ability for intelligence, consolidate decades of scientific research, and eventually autonomously develop a cure for cancer. So how do you cut through the hype? Well, if a big AI firm is talking about AGI as a vehicle to justify furthering its bottom line or accelerating AI, it's probably hype. If researchers are using decades-old algorithmic technology to solve a scientific problem, it's probably worth getting excited about.
And I know that AI Now recently did a survey of how providers and patients are seeing healthcare tools, AI healthcare tools showing up. So can you run us through what the most common versions of that are?
Totally. And here I'm so indebted to many of you in the room, my tremendous colleague, Katie Wells, who has been working with nurses and NIU on the ground to talk about this use case. So let's rip through it really quickly. First, similar to the cancer conversation, AI is showing up in many different ways. We're seeing predictive tools, algorithms that are trying to predict and detect conditions. This is showing up as both hardware, think cameras in hospital rooms that are monitoring patients, think software, like tools that are analyzing patients' charts and coming up with a predictive system. We're seeing transcription systems and software. There are tons of these products. We are seeing a suite of tools that are designed to try and tackle administrative workflows like scheduling and charting. We are talking about worker surveillance tools because we can't talk about AI in healthcare without that. It's a hugely important way that AI is showing up. A lot of the tools I just mentioned are effectively worker surveillance tools, but we're also seeing facial recognition tools and tools that are actually intermediating the ability to work. And many more that I'm sure many of you are aware of in the room, but I'll stop there.
And you said worker surveillance, so I'm guessing that's a risk. But what are some of the risks that you're seeing with how these are showing up right now?
Yeah, let's start with labor. Like, there's so much discussion right now about AI in the future taking jobs. And the reality that AI right now is working to degrade and undermine people's jobs that exist right now. So, I mean, Katie's work here talking about how AI systems are degrading the working conditions for nurses, suppressing wages, and degrading work conditions. We know that AI tools are actively undermining healthcare professionals' clinical judgment. We know that these tools are making work feel more like a business transaction than they are actually a care setting. And then very quickly, I want to touch on patient safety. We know that large-scale LLMs are inaccurate, period. They're introducing a significant amount of risk. I want to call out Epic sepsis system that was integrated in hospitals, and researchers found it was no more accurate than tossing a coin. We are seeing privacy and data concerns. And of course, we know that any claims about efficiency and productivity are making healthcare professionals work faster with less, which degrades the quality of care. But I want to ask you, given this conference, what are the risks that we're seeing in the healthcare market?
Yeah, in the market, we're seeing a whole different set of issues, which is, first of all, pricing issues. So healthcare prices, I think everyone knows in this room, they're already fake. But AI is making them even faker, in that providers and large health systems, PE firms that own formerly independent provider groups, are adopting algorithms that upcode or try to drive up the cost of services. And on the flip side, payers are adopting, insurance companies are adopting AI algorithms that are trying to drive down the cost. So there's a battle of AI algorithms trying to determine the cost that people pay for care. A subset of that is that one of the ways insurance companies are trying to drive down the cost is through automated prior authorization denials. So the providers in this room know that when they want a patient to get a procedure, they often have to submit a claim requesting permission to provide this thing that they have decided is medically necessary. A lot of insurance companies are adopting algorithms that will blanketly deny. So prior authorization denials are way up, and that is another huge issue in the way that this is showing up.
How do we think about evaluating when a tool might be useful or harmful?
I think part of the problem is that the incentives that big medicine is causing means that even the most well-intentioned entrepreneur who is building a system like this knows that they have to sell to the end payers. And the end payers are not the patients. The end payers are the big health systems, they're the PE firms, and they're the insurance providers. And therefore, these systems that they are selling have to cut costs in some way. The incentives are not necessarily for better patient care. The incentives are for claims denials or scheduling algorithms or ways to make providers see more patients faster. And big medicine is essentially warping the system, such that the builders of these systems are really struggling to build anything that's actually useful. So we're almost out of time.
Speed running this, yeah.
We know that AI could be useful. So what are the policy conditions that are necessary for it to actually be so?
Yeah, absolutely. So I'll talk a little bit about building the tech and thinking about it from a technical perspective, because you can build technology that is fit for purpose, that is validated and evaluated, that is built in collaboration with the people who are using the technology, and that puts privacy at the center. Right now, so many of you in the room are not giving a choice about when these tools are coerced onto you, and it doesn't have to be the way. And so I think about the conversation starts with rigorous testing, fit for purpose, privacy at the forward, and a huge part of this is what's happening in the market, again. So what are the conditions that we have to think so that those types of tools can be successfully implemented?
We have to break up big medicine. And with that, I think we're out of time.
Thank you.
Thanks so much to Kate. Our next speaker is Angela Hanks. She's the Chief of Policy Programs at the Century Foundation, which is also our partner for this event.
Hi, Hi, everyone. I'm Angela Hanks. I'm Chief of Policy Programs at the Century Foundation. We're really thrilled to be co-hosting this event. So we spent really all of the morning talking about the big problems of big medicine, and now we get to do the fun part, which is talk about solutions. This session is going to be a little unique, so I'm going to describe it very quickly. We have many people who are going to give short presentations on kind of big solutions to break up big medicine. But we're going to do this in a way that's sort of maybe a mix of like half Shark Tank, half congressional testimony. So people have 3 to 5 minutes to give their speeches, but they're going to get cut off. So these are very important ideas, but if they don't take 5 minutes, we can't have them. So no pressure, but those are the stakes. I will time keep. I'm going to hold up for each speaker a 1-minute warning, and we'll have a timer that goes off at 5. But we want to make sure we get through everyone, get to our last panel, and get to lunch. Just a quick note on solutions. We know that people are hungry for it, both because of what we heard this morning about the scale of the problem, but people are also telling us quite directly. Century Foundation just put out some polling yesterday that shows 2/3 of Americans want major healthcare reform, ranging everything from bigger, more expansive government role all the way to complete overhaul of the system. And you heard so much this morning about why. So really excited to hear from the panelists about solutions that can help meet the scale of the need. So with that, I'm going to bring up our first pair of speakers. So we have Emma Freer from the American Economic Liberties Project and John McDonough from Harvard to talk about their plan on vertical integration and Break Up Big Medicine Act.
Hi, Sharks. Good morning, everyone. As you've already heard several times today, big medicine dominates the U.S. healthcare system. And by big medicine, I specifically mean private insurance and conglomerates and other middlemen, big pharma manufacturers, mega hospitals, and private equity-backed practices. All of them leverage their market power and exploit financial conflicts of interest to drive cost up, quality down, and independent practitioners out of business. You've also heard that 6 vertically integrated big medicine companies rank among the Fortune 15. The biggest of them, United Health Group, is the nation's largest private insurer, largest health insurance claims processor, and largest physician employer, controlling 1 in 10 U.S. doctors. It is also the country's 3rd largest pharmacy benefit manager, 3rd largest health savings account provider, and 4th largest pharmacy operator. United Health Group is not alone in pursuing this vertically integrated business model. 4 in 5 doctors are now corporate employees, including at other insurance conglomerates, wholesale drug distributors, for-profit health systems, and private equity firms. But it wasn't always like this. In 2000, there were no big medicine companies on the Fortune 15. And in 1980, 4 in 5 doctors actually owned their own practice. So how did we get here? John will explain.
Let me say, I've done a lot of teaching and lecturing in my 45-year career, however long. This is intimidating. So one of my approaches is focusing on a lot of the problems. The problems, private equity, maximizing shareholder value, monopolization, privatization, consumer cost sharing, skin in the game, prior approval, suppression of labor unions, so many different discrete pieces that people recognize and get and feel deeply upset. And one of the pieces that's missing is that they all tie together, and they tie together in a package. And the name of the package is neoliberalism. That's really where it all started. It wasn't a plot or a conspiracy. It was an intellectual revolution that came from the right with a lot of deep funding. And more than anything, that explains it. It's tough to explain. I teach U.S. health policy at the Harvard School of Public Health. I got a class, 65 really smart, energetic, principled, young future leaders. I asked them, I say, how many of you ever heard of the word neoliberalism? 3 of them raised their hand. And I say, how'd you hear about it? They say, we heard you speak about it. So I decided I had to do something about this. So I've been spending about 5.5 years, and I wrote a book. It's coming out in August. It's called America's Wrong Turn, U.S. Healthcare in the Neoliberal Era. It's from Hopkins Press. If you use the code HTWN, you get a 30% price break for it. And it's an attempt to try to help people make sense of this period that we're in. It didn't just come spontaneously. It came because of decisions made, public policy decisions, often people not understanding what the heck they were really doing, like in the late 70s when the Department of Labor said it was okay for pension funds to give their money to private equity, and that didn't violate the prudent man standard. It was when the Bayh-Dole Act passed and academic medical centers could keep the patents and use them for their own enrichment. It was 1981-82 when Congress rewrote the guidelines for antitrust and monopoly and basically adopted Robert Bork's consumer welfare standard and gave most companies a green light for the consolidation that we see we're dealing with and suffering under today. So lots of different pieces to this, lots of different ways, and so there's an education job that needs to be part of this as we understand this in a way that will create meaning and help people make sense of this moment. And so I think that's part of it, is what's the education job going forward here to tell the public and help the public understand. I don't find it a hard sell. I don't find it a hard sell to convince people that this is real and this is a problem. I'm finding incredible interest in this, and I invite you all to be part of that as well, and if I can be helpful to you in any way, please let me know. Thanks very much.
Thanks, John. So looking ahead, how can policymakers fully end neoliberalism for good? Rather than incentivize the the big medicine business model, Congress must dismantle it by passing the bipartisan Break Up Big Medicine Act by Senators Elizabeth Warren and Josh Hawley. This federal bill would prohibit insurers, PBMs, and wholesale drug distributors from owning or controlling healthcare providers. In doing so, it would eliminate the structural conflicts of interest that are embedded in the big medicine business model. Thanks to the work of many of you in this room, there's a lot more awareness about the harms that stem from when health insurers own medical providers or when PBMs own pharmacies. But wholesalers have really largely evaded scrutiny. The big three, McKesson, Cencora, and Cardinal Health, control 98% of the drug distribution market. Each ranks among the Fortune 15, and each is also increasingly vertically integrated with medical providers, including oncology clinics and other high drug cost specialty practices. This arrangement is rife with conflicts. If your loved one had cancer, you wouldn't want their chemotherapy to be chosen based on how much it profits the wholesaler owner of that practice. Which is exactly why the Break Up Big Medicine Act specifically adds wholesalers to the mix and would break up this consolidation. American voters really strongly support this kind of reform. A recent poll commissioned by Economic Liberties found that a supermajority of both Democrats and Republicans support federal structural separation legislation, and it's not just us. Another poll conducted by a leading GOP firm found that 90% of voters agree that health insurance companies have too much control and should be broken up. There's a historical precedent for this too. FDR signed into law the Glass-Steagall Act, which structurally separated commercial banks from investment banks given the systemic risk of their common ownership. Big medicine poses a similarly catastrophic threat to the U.S. healthcare system, and Congress should act quickly to disarm it before a total collapse. The Glass-Steagall Act was just one part of the New Deal. Similarly, the Break Up Big Medicine Act should be part of a broader set of reforms enacted by Congress and state legislatures to solve the big medicine problem, as you will hear about during the rest of this session. Angela?
Thank you. Okay, that was great, but we were a little bit over time. We did have to hear about the Break Up Big Medicine Act because it's the reason we're here. And from here on out, we're going to be quite strict. So thank you to our first speakers. And let's bring up our next set of speakers, Dr. Barbara McAnee and Hayden Rookley, to talk about their idea to reform corporate practice of medicine.
first. Hi, I'm Barbara McInerney. I'm a medical oncologist running one of those independent cancer clinics. And I used to be AMA president. And when I was AMA president, my opening remark was, we live in a healthcare system that is perfectly designed to consolidate wealth and power in the hands of large corporate entities and is increasingly badly designed to actually take care of patients. I think that resounds well in this room. So since leaving that podium, this is the underlying economic reason. This is why consolidation is occurring. If you look at what Medicare, which is our big dog, it is our single payer, Medicare, Medicaid, IHS, governmental payers are well over 50% of health care, and they determine the rates. The top lines are the hospitals. That pathetic low line is what physician practices are made. The lines in the middle are our costs of doing business. I lose $90 every time I put a patient in an exam room with an oncologist for an hour. I'm supposed to make it up on the drug margin. The IRA will take away the drug margin, and that will take away cancer care delivery. So we have some problems. So what I'm looking at now, since I no longer have the AMA podium, is I'm doing several things. One, in my own practice, I've been self-insured for 10 years with 300 employees. My premiums have gone up $10 in 10 years. I have no co-pays on drugs or office visits and no deductibles. It can be done, and I can prove it. Second thing I'm working on is locally to create a clinically integrated network of independent physician-run practices with the plan of redesigning healthcare in my city. And we are succeeding in doing this. We're going to take on some of the payers, but we're also going to direct to employers. And the comment that was made earlier about where are the employers, they're out there and they're pissed, right? They are going out of business because they are paying all of their money for health care. So if we can cut out what's called the BUCAs, Blue Cross, United, Aetna, Cigna, and we can go directly and be self-insured and we can show them how to do these things, we can retransform that. The third thing that I'm working on is a group called On Care Alliance, which is a group of 30-some independent oncology practices across the country. Together, we purchase $3 billion of chemotherapy every year. So we have the ability to get the ear of pharma. And we're creating a process I call MASON, Making Accountable Sustainable Oncology Networks, which is looking at getting us off the drug margin, which frees us up from the distributors, the GPOs, and the PBMs, but you have to pay us fairly for the things that we do: care coordination, making care plans, supervising care. Get us from going from that bottom line over there where we're going under because we have seen a 30% cut in the last 25 years in terms of what we're paid while practice expense has gone up. The government's estimate of 60%. That's why practices are leaving independent practice, because if you move up to that top line, your revenue just doubled for Medicare and Medicaid and can go up 5 to 7 times for commercial payers. We are not leaving independent practice because we want a 25-year-old MBA telling us how to take care of people. We are leaving practice when we can't make payroll. Thank you.
Thanks for that, Barbara. So one way that policymakers can address big medicine and combat corporate medicine is by strengthening and actually enforcing their longstanding state bans on the corporate practice of medicine, or CPOM. So these laws actually just prohibit lay corporations, private equity investors, insurance-owned practices, national retail chains from owning medical clinics. They say that these clinics, for-profit medical clinics, need to be owned by physicians and other clinicians who are licensed to practice medicine in the state, and preferably who actually deliver medical care in the practices that they own. These laws emanate from the basic concern about corporate intrusion into the physician-patient relationship, and they actually still exist on the books in most states right now. But they've gone woefully under and unenforced over the last about 30 years in the era of corporatization. And states functionally now most states permit corporations to circumvent or contract around these laws through sophisticated legal engineering that essentially allows, oh, am I up? It allows...
Final thoughts.
That essentially allows corporate groups to operate, to manage practices through separate corporate vehicles. So not actually the medical practice, but through what are known as management companies or management services organizations. Some states, however, in the last year are starting to push back against this. Oregon in 2025 passed a law that placed unprecedented restrictions on these management companies, these management services organizations, and that already actually is beginning to bear fruit, as you heard from Senator Wyden earlier today in his discussion about the litigation in Eugene against Peace Health and Apollo MD. I actually had the privilege of representing the physicians in that case. This was a classic physician group that's been in the community, Democratic group for 40 years, been staffing the local emergency room. They, after raising patient safety concerns with the hospital administration, raising concerns about actually administrators meddling in clinical care decisions, the hospital then responded by trying to oust the physician group and replace them with a national investor-backed staffing, corporate staffing company out of Georgia. We immediately sued and were able to quickly prevail, get our clients, get our physicians back into the emergency room when we were able to show that this corporation, this management company, was likely operating illegally under Oregon's brand new CPOM law. Just after Oregon passed that law last year, California passed a statute giving more enforcement authority to the AG in that state, which he's using in some pretty interesting ways in the last few months. Just in the last few weeks, Vermont passed a statute signed by a Republican governor which is a kind of a narrower version of the Oregon law specific to private equity. We're seeing a number of these bills pop up in states across the country. So this is one potentially quite potent way that states, also the federal government, Senator Wyden mentioned this today, can act on this front as well to protect medical clinics, keep them local, and ensure that they remain accountable to their patients and to their communities.
Okay, huge update. I just got news that I have been doing this wrong. Each individual person gets 5 minutes. So for people who are going up in duos and are worried that I'm going to cut you off as soon as the second speaker comes up, I have great news. I'm not going to do that. So with that, I'll bring up our next duo of speakers to talk about pricing policy, Irene Papanikolas and Natasha Murphy.
All right. Hi, everyone. I'm here to tell you that the U.S. has a spending problem. In 2024, the U.S. paid approximately $15,500 per person for health care. That's money that comes from households, from taxes, from premiums, from deductibles, from foregone wages that employers are paying for health care costs. That's also 2.5 times what other high-income countries spend. Even the next highest healthcare spender, Switzerland, spent $10,000 per person on healthcare. Maybe this would be okay if we were getting a good return for spending, but we're not. Last year, we had the highest life expectancy ever recorded in the U.S., 79 years at birth. That's still about 5 years lower than the next 10 highest spenders are achieving, all in their 80s. Not only are we getting worse life expectancy, we cover not all the population. Millions of Americans are uninsured. And even Americans who are insured can't afford their care. Gallup estimates came out last week indicating that 50% of Americans struggle to routinely cover healthcare costs. Why? There are many explanations, and the answer to this question is fundamental for the correct policy response. Economists have a simple way of working this out. Healthcare spending is how much healthcare we consume times the prices we pay. If we're spending 2.5 times more than other countries, are we using 2.5 times more care? If we are, then we should address utilization. How do we do that? Through things like cost sharing, prior auth, moving away from a fee-for-service model, policies we've been implementing for decades. If it's not, we need a different set of solutions. We need to target prices. So what is it? Why is healthcare spending so high? We can look at data on this. We know what other countries use and pay. And when we look at utilization, the picture is pretty clear. Americans go to the doctor about 4 times a year. Other high-income countries have people on average going to the doctor about 6 times. Americans go to the hospital less. Common procedures like knee replacements, hip replacements, cataracts are about average. There are some things we use more of, like MRIs and longer institutional rehab days, but on average, we're pretty average. We're not utilizing care 2.5 times more than patients in other countries. So if it's not utilization, it's prices. And when we look at the data on prices, that's also pretty clear. The Americans spend way more on healthcare no matter where you look. Hospital services are more expensive, physician services are more expensive, drugs are more expensive. And typically, we're comparing Medicare rates to other countries. We know commercial prices are 2 to 3 times greater than Medicare. So this pricing problem is very prevalent in our system. So the fundamental question then becomes, why are prices so high? In most markets, competition is supposed to keep prices in check, but healthcare markets often don't work that way. Most communities are dominated by small numbers of hospital systems and physicians groups, and this has gotten worse over time as we've seen consolidation. As providers consolidate, they gain negotiating leverage and market power, allowing them to command higher prices. Add to this that patients rarely have the information, time, or ability to shop around, and you have a big pricing problem. As a result, prices reflect market power more than they reflect competition. Now, other high-income countries who spend less take a different approach. Some don't rely on markets at all, but not all. Some rely on markets, like the Netherlands, Switzerland, Germany. They have private providers and, in many cases, private insurers and competition. But they don't allow prices to be freely determined by local bargaining power. They set guardrails around prices using fee schedules, negotiated budgets, and other mechanisms to control competition. So this is why these countries are able to cover their entire population, get better access to care, and spend 2.5 times less than what the U.S. spends. The data is clear, backed by decades of national and international research. High prices are the culprit behind high U.S. spending. And when prices are the primary driver of spending, policies aimed solely at utilization aren't going to do the trick. We need to target prices if we want to rein in U.S. health spending.
Wow, 9 seconds to spare. That was great.
Good afternoon, everyone. So today's affordability crisis is not just a cost problem, it's a power problem. 94% of U.S. hospital markets are highly concentrated, and commercial insurers and employers pay hospitals on average about 2.5 times what Medicare pays for the same services. And with hospital prices accounting for nearly 40% of private insurance spending and having served as one of the largest drivers of recent healthcare costs, as Irene just laid out, these higher prices are not the result of Americans utilizing more care or even getting a greater value of care. It's really the product of this outsized market power. And the consequences are truly felt everywhere. Families are paying more in premiums, higher out-of-pocket costs, and employers are facing rising health benefit costs, with workers ultimately paying the price in the form of slower wage growth. So if affordability is fundamentally a power problem, then the solution has to be focused on restoring balance. And that's where price regulation can come in. It's a way to redistribute power away from these dominant health and hospital systems back towards the public purchasers, employers, workers, and patients. And it's about making sure that healthcare prices actually reflect value and not a health system's negotiating leverage. And the encouraging news is that we don't have to imagine what this looks like. We've already heard today that states are really leading the way and building the roadmap on action. So Rhode Island showed, kind of how thoughtful price regulation can work, limiting hospital price growth through its affordability standards. And over the last years, we've seen additional states take up that mantle. We heard from Kristen earlier about the fantastic work happening in Delaware, and lawmakers in Maine, Massachusetts, Michigan, Oklahoma, Oklahoma, Indiana, and Vermont, have also taken action to enact hospital price caps, whether it's in the commercial market or leveraging the state employee health benefit program. And so taken together, this shows us that, hospital price regulation is no longer kind of a fringe policy idea. It is really becoming a mainstream affordability strategy that's picking up steam across political lines. Whether the motivation is, consumer affordability, employer cost relief, pro-competition policy, or simply taxpayer stewardship, lawmakers across the ideological spectrum are reaching the same conclusion that excessive hospital pricing really requires an immediate and swift policy response. And so at CAP, we recently proposed building on state momentum with a targeted federal approach to regulate hospital prices with two core components. So first, highly concentrated markets where competition has already broken down, we would cap prices at no more than 3 times Medicare rates. And also we would propose limits on additional kind of annual price growth, not just the price levels. So for hospitals that are charging above the statewide median, we'd cap annual price increases at inflation plus 1 percentage point. So leveraging the Rhode Island model. But overall, this is a tested concrete strategy to help take back power from these dominant health systems. So overall, price regulation isn't the sole answer, but it's definitely one of the clearest and most direct ways to restore balance where competition in healthcare markets have failed. Healthy regulation is really critical to creating that downward pressure on costs and aligning incentives to ensure that the consumers are no longer facing the significant financial burden that they currently are. Ultimately, policymakers do not have to accept rising hospital prices as an inevitable reality. They can intervene thoughtfully and in targeted ways through price regulation. So thank you.
That was great. Thank you so much for modeling for our other speakers. Our next speaker is actually not here today. Speaking of healthcare, she's home with sick kids, so she can't make it. But Hannah Garden-Monheit with the Center for Law and Economy and Economic Liberties has a proposal on double dignity issues, and I think we have a slide. Okay, we don't have a slide, but I'll tell you a little bit about it, and then it's also in your ideas packet if you want to learn more later on. But basically, Hannah's proposal is 3 straightforward, discrete policy interventions that can help restore double dignity to healthcare jobs. So this means improving jobs for healthcare workers while also boosting the dignity of vulnerable patients. So the 3 ideas are a ban on non-competes in healthcare, which would boost workers' power, while saving somewhere in the range of $74 to $194 billion over the next decade and reduce spending on physician services, a ban on prior authorization, which would free up time, equivalent of our entire projected physician shortage in time now spent on paperwork. And then finally, minimum safe staffing requirements to ensure owners hire enough human workers to provide safe care, prevent burnout, and boosting safety. And the rule proposed under the Biden administration would have saved an estimated 13,000 lives annually, and I think you'll hear more about staffing ratios in the next panel as well. Okay, so moving on to our next topic and speaker on patents, we have Taher Amin from the Initiative for Medicines, Access, and Knowledge.
So this 5-minute format feels like testifying before Congress, but...
Someone else does.
Oh, okay. Well, I'll switch myself off. 1 in 3 Americans struggle to fill their prescriptions. You've probably heard that statistic. They skip doses, cut pills to get by. For the past half-century, neoliberal economic policies, a word you've already heard about today, have been championed under the banner of innovation, allowing for greater privatization of public knowledge in exchange for private investment. As a consequence, these policies expanded what can be patented, resulting in a system which pharmaceutical companies routinely obtain patents on minor modifications to existing drugs, extending monopolies far beyond any genuine invention and extracting rents on knowledge the public has already paid for. So my organization did a survey last year, a nationwide one, where 80% of respondents said they wanted to see patent reform in order to see earlier generic competition. So I've got 2 solutions. One is restricting the type of subject matter that can be patented. So that could mean preventing companies patenting naturally occurring substances, and that also includes modifications to them, especially when you think about psychedelics. And also raising the bar for what it is to get a patent in the first place. And this reduces the ability of pharmaceutical companies to extend their monopoly practices. And just to follow John's lead, if you want to learn more about how neoliberalism shaped the patent system or the pharmaceutical system, you can read my new book, Pharma Monopoly.
I have to say, I'm very grateful for the people who wrote an entire book to cheat on the 5-minute timing. Very convenient, very useful. Please get John's book. Please get Taher's book. Okay, we're moving on to our next speaker, who is Dana Brown from the Vanderbilt Policy Accelerator, and she's here to talk about generic drug manufacturing.
Okay, everybody, I hope you had your coffee because I'm going to need your participation for a couple of seconds. I'm going to do a quick survey. First, who in the room paid their federal income taxes last year? Have you paid at least $1? Yeah, great, thank you. I paid for my taxes too. Guess who didn't pay any federal income tax last year, despite breaking in billions of dollars? CVS is definitely on the list. I'm looking exclusively at the big pharma companies right now. At least Pfizer, AbbVie, Merck, Amgen, and Johnson & Johnson paid $0 in federal income tax last year. As Thakur mentioned, who in the room knows anyone who has ever gone to the pharmacy and then decided not to fill their prescription because of cost? Me? Okay, that's a lot of people. Any clinicians in the room ever have to use a second or third line treatment because the first line treatment was not available? Yeah. Anyone have any idea how long the average drug shortage in the United States lasts now? 5.3 years. We're hitting new heights these days. Make America great. Has anybody in the room ever tried to pass legislation or get new regulations put in and been beaten back by Big Pharma? Meredith, I see you. Yep. All of that is a problem, right? That's all the problem that I'm here to talk about today, which is an industry oriented solely around profit maximization, naturally leads us to these outcomes. And the industry in question right now is the industry that supposedly provides us essential medicines. As Tahir's book actually goes into great detail on, they produce more patents than medicines, but that's a whole other problem that you should read about. In many countries of the world, we consider essential medicines to be an essential good. Yet in the United States, under neoliberalism, we've treated them as a commodity. And I think that is the main issue. So the solution that I'm here to talk about today, and I've got my improv hat on, is a yes and one, right? So break up big medicine and provide meaningful market discipline to big pharma by a robust public option. I've got up there, we're going to talk about all this. One thing that when I talk about public options in pharma, journalists always ask me, is it possible? Is it practical? Is it pragmatic in this political context? First of all, we're already doing it, just on a very small scale. We've done it in the past, and we can do it again. The question is about political will, but it's also about all of us understanding that it can and should be done. So real quick, because they are not beholden to shareholders or market imperatives, public pharmaceutical enterprises are free from the pressures of profit maximization and rent-seeking. So they can define their bottom line a different way. The bottom line could be about public health, scientific advancement, or economic resilience. This allows public pharmaceutical entities to distribute medications at cost, cost plus, or even below cost. You can distribute medicine for free when it's good for the public. Versions of this approach exist already around the world, from Brazil to Thailand, UK, Sweden, I could go on and on. The U.S. also has a long history of government involvement in medicine manufacturing. The state of Massachusetts has been discovering and manufacturing drugs in the private sector since 1894. The state of Michigan produced biopharmaceuticals, vaccines, antitoxins, other medications in the public sector for decades until that plant was privatized in the late 90s. Public health departments around the country have historically manufactured products ranging from vaccines to antitoxins. They produced the world's first treatment for infant botulism. Federal facilities continue to produce certain medicines and medical countermeasures today. And in recent years, we've seen renewed interest in public production as a way to lower prices, expand access, strengthen supply chains, and crucially, to build public power. This is particularly true at the state level. So a lot of you know about CalRx. California has an initiative that has already brought low-cost, high-quality insulin and naloxone to the market through the public sector, and they're currently working on an albuterol inhaler program. largely spurred by California's success, but also pressure from their constituents. The states of Michigan, Maine, Illinois, New York, Connecticut, and Ohio, and probably others, those are the ones I know to date, have introduced legislation, funded studies, or otherwise explored public production of pharmaceuticals in recent years. States are also collaborating in new ways through initiatives such as ArrayRx. Any ArrayRx folks in the room? ArrayRx is a multi-state consortium focused on pharmacy services. So they provide independent PBM services, a discount drug program, et cetera. And they're also already exploring the option of public production. Currently, Washington, Oregon, Nevada, Connecticut, Ohio, and Arizona participate in ArrayRx. And as more states and jurisdictions join, they're there to serve the state's needs. If more states say that they want to get into public production, okay, then ArrayRx could serve as a vehicle for that. Blah, 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 blah. Cities can get into the game too. Chicago has a pilot for public distribution of medications. My colleague Joel Dodge and I just published a report about how New York could do something similar. In sum, renewed interest in public pharmaceutical production creates opportunities to lower drug prices, create good jobs in the public sector, build more robust and resilient supply chains, and build public power to counterbalance against big pharma. Thanks.
Okay, Dana got a little extra time because she did the extra Shark Tank vibe and did some public participation. So if other folks want to follow that too, that's fine. Okay, our next speaker on middlemen is Julie Selesnik from Health Plan Legal Counsel PLLC.
Hi, everybody. My name is Julie Selesnik. I'm an attorney in D.C., sorry. But I come at this by way of being a longtime plaintiff-side class action attorney and focused in the ERISA space, if everyone really wants to get excited. And then, about a decade ago, we transitioned over to looking at health plans. And we were like, my goodness, this is super dysfunctional. We thought 401ks were something, but we couldn't even figure out who to sue. And we're like, okay, and historically we loved suing employers, and we're like, we don't even think we can sue them here because they can't get their data. They don't know what the contracts that they're bound by say. They have all these people in between them and the medicine that they're purchasing for their employees that are preventing them from being good fiduciaries. So over the course of the past decade, my career has transitioned to only litigating against carriers and PBMs, and now advising employers and trying to work with employers and employees to make better health plans, to get away from large insurance carriers and PBMs, try and do things like direct contracting, because here are the problems that currently exist. First of all, employers purchase, they're the majority purchaser of commercial health care in this country. 165 million adult Americans that are under the age of 65 are covered under employer-sponsored plans. Now, 65% of those plans are self-funded. That means that the employer and the employees have the risk, mainly the employer who pays the lion's share, and then maybe they have something called stop-loss insurance on top for catastrophic claims, but it's not what people think, that it's a traditional insurance policy. Unfortunately, usually there's still an insurance company involved. They're called a third-party administrator, TPA. They give you access to their network, which is how you get to go to the hospital that you want to go to have your employees have access to. Then they price your claims according to their network contracts that you cannot see if you're an employer. So you are to assume that these are being priced the way they're supposed to, based on contracts you're not allowed to see. And then when you ask to see them, it sets off a huge chain of catastrophic events. And eventually, if you do find an error, that same third-party administrator will charge you 35% to recover their own mistake and give you your money back. So there's all kinds of middlemen like this throughout every employer-sponsored plan. You pay for mistakes to be found and fixed. If it's out of network, you pay something like between 30 and 40%, the difference between the price that's charged on the charge master for whatever happened and the reprice. So a bunch of people out there in the healthcare industry get paid by putting a new price on the price of healthcare. So it comes out with some crazy price to begin with. Then one company says, this is what this is going to cost. We'll take 40% of that difference. But then another company comes in from the other side and says, it's going to cost this. Sometimes you have to go to dispute resolution, pay for all of that to determine how it's going to be cost. So these are layers and layers. Every dollar that goes to this is a dollar that doesn't go to healthcare. You also have brokers that are supposed to advise the plan and give them the option, all of their options, but brokers are often paid by the people they're recommending that you use. So the broker can get paid by the PBM, by an insurance carrier. Only since 2021 do employers even know this is happening through something called a compensation disclosure, but they still don't get real numbers. You get formulas and things like that. So how do we fix all of this? One, you continue, there has to be targeted litigation, and there is. There's great antitrust litigation that's going on even now against Ohio Health, against New York Presbyterian, against Sutter Health a few years ago. Private litigation also follows, and this is state and federal litigation together, along with private litigation to enforce our existing antitrust laws. We also have cases against PBMs for insulin price fixing, for price fixing in general. The FTC actually just settled with the big three, Optum, Express Scripts International, and Express Scripts Inc., which is Cigna, and Caremark, which is CVS, and they now have to offer, as part of this settlement, a sort of no rebate, no spread pricing model starting next year. So employers have to demand that. We need to pass the Break Up Big Medicine Act, and we need more than that. We need a law that bans these provisions in hospital and insurance contracts, anti-steering, anti-tiering, all or nothing clauses. The Council of Economic Advisors just came out with a report this week that said prices would fall in affected regions 18% if those were banned. In the meanwhile, until all of these things happen, employers need to do some self-help, and that means trying to do direct contracting. Contract directly for your services. Don't use a BUCA, as Dr. Magnani said. You can use an independent TPA. Use a pass-through, transparent PBM. Stop engaging in the system that is causing all of this and start finding all of the other avenues that exist to enter into better, higher quality, lower cost contracts. Thank you.
Amazing. Thank you so much, Julie. And then we're at our last speaker, which is Alex Jaquez from Groundwork Collaborative, to talk about an American healthcare service.
All right. They put me last to make sure that we got out of here on time, so I will come in at under 2 minutes here. We've heard a lot today about the markets that are broken in pharmaceutical drugs, in the healthcare hospital marketplaces, the way we price our pharmaceuticals, the way that the system really just fails at every single turn. But I think what we have talked maybe less about is the people, the men and women who provide the care, the facilities in which they provide that care, which is why I want to talk about the creation of an American health service. Just as critical and much less explored by progressives in these debates than Medicare for all versus a public option is the doctors, nurses, clinics, and hospitals who are providing the backbone of our care service. As our population ages and consumes more health care, the stresses on our current system will only intensify. Since 2005, 200 rural community clinics and hospitals have closed. After Trump's cuts to Medicaid and the cuts in the One Big Beautiful Bill Act, more than 700 rural hospitals are at threat of closure. We also face a shortage of physicians that is set to grow to 85,000 in just under a decade. We have 350,000 nursing positions that are currently unfilled. 12% of doctors currently practice in primary care, about 1/2 to 1/3 as many as we need compared to peer countries, and 10% practice in rural areas where 20% of the population lives. We are getting older. Our physicians are getting older through retirement and attrition. We expect to lose even more of these doctors, leaving hundreds of thousands of people, millions of people in care deserts for primary care and critical mental health services. Of course, how did this happen? Consolidation, corporate power, and the market incentives that push funding toward specialties like orthopedics and out of family medicine and general practitioners. Our current public health infrastructure is completely inadequate to meet this challenge. Community health centers are radically underfunded despite coming in at lower cost and covering a sicker population. The National Health Service Corps deploys just 17,000 providers at present. We need a radical rethinking of how we deliver publicly provisioned care in the United States, and so a coordinated public American health service to tackle this monumental challenge is necessary. First, we should reimagine and scale community health centers. They should no longer just be the anchors of a safety net system, but provide universal primary care to all who need it. They should be extended to service to middle-class patients. They should expand their services to make sure they include things like mental health counseling and pharmacies at all locations, and be adequately funded so that we are able to shrink those healthcare deserts, particularly those primary care deserts. Second, we should institute a 21st Century Hill-Burton Act. It's a post-World War II program that built more than 7,000 public hospitals in the United States that still provide free and reduced care to this day. We have switched since 1950 from about a third of our hospitals and clinics being public to about a quarter being for-profit, and as we all know, nonprofit, not much different these days at all. So, public hospitals would be placed to meet minimum ratios of beds per population. They would serve as teaching centers for a new class of practitioners and medical residency slots, and they would use global budgets and price caps to compete directly with the nonprofit and for-profit hospitals that are currently inflating costs and driving up prices. And then third, we should staff these facilities with tens of thousands of new publicly employed providers, expanding residency and medical school slots with an explicit focus on building out a robust primary care service. They should be supported by community health practitioners in the way that is done in Costa Rica and Brazil and other countries to ensure that we have a fully integrated primary care and community care system. I think we should do that all tomorrow. It'll serve the backbone of a universal program. Thank you very much. I'm done.
Thank you so much to Alex. That was 4 minutes. It was not 2, but it was shortest speech yet, so great job. And just one more thank you to all of our panelists for speaking today. Okay, next up, I'm going to turn over to my colleague, my boss, Julie Morgan, who's the president of the Century Foundation, to talk with panelists about how people are mobilizing to break up big medicine.
Hi. I'm a little nervous being the panel that sits between this group and lunch, but I think it's worth the wait because I feel like I've been waiting all day to hear from this group, even though we've got some tough acts to follow today. I'll just introduce myself again. I'm Julie Morgan. I'm the president of the Century Foundation, and one of the reasons I'm really excited to hear from these panelists is that we've heard a lot today about the problems in our healthcare system and how they're affecting patients, right? Throughout that, we heard a lot about corporate power. We heard a lot about the big lobbyists who have kind of hijacked our healthcare system over the past several decades and really bent the law to their will. And we're seeing that system break right now, right? Everyone, I think, in this room has felt that in their daily lives and has seen that in the lives of the people that they serve. We've heard a lot about some of the solutions that we could bring to fix that problem, but in order to do that, we have to build some power for ourselves. And we have 2 women here today who are working to build that power on behalf of workers and on behalf of patients. So we have Jamila Headley, who is the Executive Director of Patients Union, and Shauna Schultz, who is an RN who's here representing National Nurses United. And I'm actually not going to give more of an introduction to you two because I want you to introduce yourselves. So let's start with our first question as, give us an introduction to yourself, tell us about how you came to this work on breaking up big medicine, and tell us a little bit about how you're building power through your organizations.
Well, my name is Shauna Schultz. Nursing was a midlife career change for me. I started a couple weeks before the pandemic. So when I started, we still had 4-to-1 ratios, and then I experienced the pandemic. I took about 1.5 years off after the first year of the pandemic with my second kid. I was a pregnant COVID nurse. And when I came back, I was really startled to find that all the nurses were new grads or travelers. There's no longer any institutional knowledge, no longer any crusty old nurse to take you under her wing. And as I saw the changes, I realized the most actionable way I had in Asheville, North Carolina, I work for Mission Hospital, was to join the union and be a burr in their side. So here I am.
Hi, I'm Jamila. I'm really happy to be here. I come to this work first and foremost as a patient. Almost 20 years ago now, I was really suddenly paralyzed from the waist down while I was uninsured. Now, these were the days before the Affordable Care Act, and it is hard to remember those days. They were pretty dark days where people like me who were uninsured and severely ill were then uninsurable. So primarily I come to this work in that way, and I'm constantly navigating as someone with a disability, as someone with a neurological condition, the world of corporate medicine and the ways that it erects a million barriers between us and the care we need. So that's what brings me here and why I'm thinking about power to change it.
And I understand that you all, although you met the other day, have some overlapping areas of interest and work going on in your hospital in North Carolina. Could you all talk a little bit about that?
You should probably start, though, because you've been doing the work longer.
Well, tell your story.
Okay. So I think the easiest thing to speak to is our ratios. Standard med-surg ratios, nurses should have 4 patients. Every time a nurse gets one more patient, her or his patient's risk of mortality increases 7 to 16%. So I have 6 patients pretty much every day. Night shift has 7, and that's pretty good. In Florida, the day shift has 7 and night shift has 8, and some hospitals don't cap it at all. So what that feels like for a patient like you, I mean, the work I do touching people, physically touching people when they're at their most vulnerable, when their legs just stopped working, it's hard to do the work that someone needs to be well. If you can't physically get them out of bed, if you can't toilet them, if they're laying in their own excrement, every day in a hospital, even at 4 to 1, a patient loses 2 to 5% of their muscle mass. So when someone comes in at a baseline of health, or if they come in frail, and we are understaffed and we can't get you out of bed, your chance of returning to wellness and surviving any length of time plummets.
Yeah. So Shauna and I only realized that we had this connection of mission in common when we were preparing for this panel. Because over the last couple of months, our team at the Patients Union has found ourselves organizing patients in Asheville. And I want to tell you a little bit about what we are observing, because it is exactly the effects of big medicine. In 2019, the Healthcare Corporation of America, HCA, came in and bought up a virtual monopoly of a nonprofit hospital in Western North Carolina. They promised the sun, the moon, and the stars. They promised that they would increase staffing ratios. They promised that patients' outcomes would improve. They promised increased charity care. And within a year, it was clear that all of those promises were not just empty promises, but that this hospital was on the path to doing irreparable harm to the community. A few months ago, our team was out just talking to patients across Western North Carolina, and we didn't start the conversation with Mission, but Mission came up in almost every conversation. People having a stroke and begging the paramedics not to take them to that hospital because they know what other family members have had to endure due to staffing shortages. Patient safety assistants and other staff there who describe being severely understaffed, unable to take the breaks that they need. A hospital that has had 4 immediate jeopardies from CMS, and for the healthcare and former CMS folks in the room, you know that is an incredibly rare designation that depicts when a hospital is putting patients at risk. In the last 5 years, Mission has had 4 of them. A hospital where just a few weeks ago, a patient in a psychiatric unit died by suicide in the hospital, who should have had a 24-hour sitter, who should have been in the one place where someone could be caring for them, and wasn't. The damage, not just to the workers, the moral harm and injury to workers who spent their lives training to care for people and are hamstrung to do so, and the damage to patients and to communities all over Western North Carolina is pretty profound and unlike anything I've ever seen. All of this by the second most profitable hospital in HCA's network right now. Wow. With the worst staffing ratios in the state, actually, and in the region. So that is the impact of big medicine, and people are seeing it and living it every day across Western North Carolina. We talked about it today in like sort of broad terms, but the human impact is really significant. Loved ones dying without the care that they need, people waiting for hours in emergency rooms, people sitting in their own excrement because somebody can't come change them, or because the hospital is low on continence pads, and people ultimately begging not to be taken to a place that once was a jewel of healthcare and a beacon of good healthcare in our state.
I want to pick up a little bit on that theme of profit, because I think that's at the core of a lot of what we're talking about today, right? Is that patients' rights and workers' rights are being traded for profit. Shauna, can you tell us a little bit more? I think you mentioned a little bit already, but how is the profit motive showing up in your patient care?
There are so many ways, it's really hard to pick just one. I think something interesting I hadn't really thought about before was that HCA has its own travel company. Mm-hmm. And so, as I said, we're all travelers or new grads, very few core staff. So whenever they staff us with their own travelers, they're making a profit on that aspect as well. And over the years, we've occasionally achieved equilibrium on our unit where we have a good team, things are going well. And then HCA calls the travelers that have been there long enough to become effective, they call them embedded, and they force them to move on. So every few months we get new travelers. And anybody who's worked in a corporate office job, you know, the first year you're just getting your legs under you. So every few months we get new people, some of whom don't really have hospital background. Recently, our travelers were in psych, not in trauma, med-surg, and they don't really remember those skills. So the few of us who are core are holding it down. Additionally, what the union has noticed is when we do win fights, it's when union members show up in mass in our physical bodies to confront our management. And if you don't have core staff, you can't show up. You cannot advocate for yourself. So that's one aspect. They're making money by destabilizing us. Another is what we've been sort of referring to as malicious discharges, the push towards discharges that are unsafe. So, we all know insurance doesn't like to pay for rehab, and patients can fight that, but it is a gamble. They have a pretty good chance of getting to go to rehab if they fight it, but if they don't succeed, they extend their hospital stay by 5 to 8 days, which is muscle wasting, increased risk for blood clots, not to mention depression, and they all know that the medical bills are waiting for them. And most people cannot afford to take that gamble. And when they don't take that gamble, the hospital shifts into the fastest discharge that they can that's not safe. And a memory I have that lives in my heart is a homeless man who everybody said, oh, he keeps coming back. He keeps coming back. Everyone got very dismissive of him. Well, he kept coming back because he couldn't walk, and he needed a walker, just a little sit-to-stand walker, and he needed a ride to a shelter. And our case manager was going to set it up for him. Mission said, no, he's got to go now. I wheeled him with my hands to a bus stop where the crappy wheelchair that we had wrestled up for him could not fit on a bus. So I wheeled him back up to my unit, and we found somebody had left exactly the kind of walker that he needed. It was just rattling around in an old room, and they said, well, this patient hasn't come back for it. Give it to him. I wheeled him back down to the bus stop, and darn it, once he had that walker, he stopped coming back. So these discharges don't save us money, they don't save us time, and they certainly don't promote health.
Wow. I mean, everything you're describing, I think, is pretty much the opposite of what patients expect when they walk in the door of a hospital and the kind of care they hope to be receiving. We hope to be treated by a nurse like you, and instead the hospitals are actually acting to kind of break up your ability to serve your patients. Jamila, can you tell us a little bit about how and whether the experiences that you're seeing in North Carolina and with HCA resonate across the country?
I mean, several people have spoken about it already today. I mean, even just from the more recent polling and the data, we know that, anywhere from a third to two-thirds of Americans are like just struggling, making massive trade-offs between, gas for their car or rent or food to pay for healthcare costs. Many people are struggling, and our experience has been that every town, every room, every space that we go to, there are actually people struggling. In fact, I'm sort of curious, even in this room, like, how many people have ever been uninsured, right? Like, how many people have ever not been able to afford their meds or had their, insurance company delay access to their meds that they needed? How many people have had a hospital bill that they couldn't pay that was large, that they were scared to do, that they had to put on a credit card or figure out to get help with? This healthcare, what we're experiencing is that in every room we go in, literally in a few questions, every hand will be raised. That actually one thing that Americans share in common in a moment of so much fracture in our country is that healthcare, what should be healthcare, right? Like corporate capture of healthcare has broken our hearts. Almost everybody has a story of that. And that, I think, is like the basis of power, right? Like, Shauna, as you were just talking, it's like there's so much union busting from HCA of the nurses, bringing the travelers in, making sure that there's not permanent staff to unionize and really change the hospital. And this is the only nurses union in our state. Like, you have to understand, like, these nurses are holding down a fort, that the nurses at Mission, that is like pretty steep and pretty wild. But you know what? Tens of thousands of patients can come beside you. And that's what we're trying to build in Western North Carolina now, that nurses don't have to fight HCA alone, but actually that the many, many patients who are being harmed by the care and being harmed by the corporation can come together and fight back with you. I think that's the only path to breaking up big medicine in this country. I don't see where else the power is going to come from. It's going to come from all of us who have bodies that break and need help and need support and need health care, really demanding real change in our country. And my experience talking to many patients now, every week, is that people are ready. People understand that what's wrong with the system is that it's a system that prioritizes profit and greed over their health, and people want something different. On Monday, we have a couple hundred people, RSVP to come to grieve the state of Mission together and to plot a path forward for how we build a patients' union in Western North Carolina that can fight back against what HCA is doing to the western part of our state. And that those things are giving me hope. People, strangers, will come to a room together because they have enough at stake in this fight to really put real skin in the game and to put their time and their energy into the fight.
And Jamila, for those of us who are not familiar with patient organizing, can you tell us a little bit about how you actually approach doing that kind of organizing, what the challenges are?
Yeah, I mean, there's so much. We're in a mode of trying lots of things. We are building what I think is this country's first union of patients. We are a membership organization made up of and for and by patients across the country. We have ambitious plans. We think we can build a membership of millions of people, given the level of pain that is already here in this country and the pain that is coming in the coming years that we know. And we are meeting patients in all sorts of ways. So, a few weeks ago, I was in Western North Carolina in Weaverville in someone's living room with 30 strangers who were all invited by someone. Someone met on the street canvassing, some people through digital outreach, some people through a friend of a friend, who came together to talk about what they're grieving in terms of their experiences with this healthcare system. And we start there. We actually start with, what are you grieving about an experience with this healthcare system? And what we hear from people in the room is heartbreaking stories from literally every single person in the room. We've done this now dozens of times, and every single time it's the same. And then that room turned into like, okay, well, what do we do about it? What do we do about mission? What's the next step? And that is what we do, is moving from sharing that grief and sharing that commonality, people who across political divides, across race, across gender, across class, coming in a room together and realizing that they all have a common pain point in this healthcare system. I think the other thing that has been happening that I find really beautiful is just last week at a patient's table, we both asked the question, what are you grieving about the healthcare system? And we asked people to also share an experience of when they have felt cared for by the healthcare system. And the commonalities were all of the grief was from greed and a system and bureaucracy, and all of the care was from nurses and doctors and PTs, and patient safety assistants was from people, from humans. And I think it provides a path for how we organize our way out of the mess that we are here, workers and patients standing together and fighting for dignity in healthcare, fighting for the very basic things that anyone in any democracy should have, access to healthcare. And it provides a path also towards what the healthcare system needs to look like. One that centers patients, one that treats workers with dignity, one that's centered on the humanness of all of us as people with bodies, who need care. And so we're learning a lot but we're doing everything from digital outreach and bringing people who are complete strangers from Facebook in person into rooms like we will in Nashville, to canvassing on the street, to all sorts of to figuring out how to get doctors help organize patients and nurses help organize patients. And lots of different experiments to figure out how we actually find the people who we believe are ready actually to be activated, and more we're finding more yeses than no for people who are ready to join a fight.
Well, I want to ask you both a little bit about that, because you're both working with groups who are extraordinarily busy and also bogged down by the healthcare system in one way or another, right? So for a patient, to actually be able to get outside of your own struggle with your medical bills and come to a meeting or to organize at a hospital, or for healthcare workers who have kids in school, are dealing with the same kinds of life struggles the rest of us are dealing with, sometimes at lower wages than what they ought to have. What are the things that you think motivate people? Are there particular misdeeds that are this is the straw that breaks the camel's back, or is it just the overall confluence of, your working situation?
That is an interesting question. What I have seen with the union is presence. So, I've heard a lot of people who work in healthcare talking about the disconnect between management and the people doing the labor, and that is very true at Mission Hospital. So, my management is super out of touch and very rarely on the floor. And that is not true for our labor reps. God bless them. They show up on the weekends. They show up on the night shift. They are deeply present, and they bring food. That seems to be it's a good strategy. They also are really good at getting answers in a timely fashion. I don't know what it is with HCA, but they seem to like to sow a lot of confusion. So even if you do have a manager who is trying to get you answers in good faith, it's not easy for them to get those answers. But the labor reps can often get answers a little more quickly. I think because some of the federal protections, they can really push for answers a little more quickly and can disseminate it to people. So being able to answer people's question and give them actionable data, like, hey, I heard there was a raise, but I think my, years of experience got counted wrong, and getting that answer from a labor rep faster than your own manager is pretty motivational for people. Recently, a gal named Molly got retaliated against, and we were all wearing stickers in support of Molly, and some of us didn't take our stickers off when management asked us to. I was one of these people. And I wasn't actually that active in the union before this, but when we're going through the grievance process, which we're still in the thick of, I noticed that all the people showing up for me were like, well, they were like me, frizzy-haired, breathless. I just dropped the kids off. I'm here for the meeting. And I'm like, oh, my God, the union is just my coworkers. Oh, my God, I have to do more. And so I think that's, as people see that it's just people. It's not the union. It's not some big organizational thing that's got their back. It's their colleagues. It's their really busy colleagues sticking up for them that gets people actually paradoxically more involved. Sometimes the carrot and the stick, sometimes the stick's pretty motivational. People get angry.
Yeah. It's interesting. I think it's the people, it's the care, it's community that brings people in and helps them stay. Our model is not just that we engage in these fights on a local level to stop a hospital merger or to stop a bad corporate actor from undermining people's health care. And not only do we work nationally to see how we can shift what's possible in healthcare in this country, but we also have a team of people who are figuring out how to help people right now navigate an insurance claim denial, navigate a hospital bill that they can't pay, figure out how to deal with low staffing in a hospital and how to navigate that. And a team focused on services for our members so that people can get what they need right now. And an important frame that we bring to that is actually part of how you get what you need is not just through some expert coming in and helping you, but it's actually us flanking each other. It's patients packing a courtroom at a debt collection hearing. It's patients showing up with food for the person who just had surgery. It's people showing up to help people figure out how, outside a insurance corporation that's denying someone care and sticking up for them and calling for that. And that actually in that solidarity and that collective action together, that is where care comes from. That's care, right? And so for us, we are building a membership organization for patients that actually, first and foremost, I hope that the experience when people sign up or walk through our door of a meeting is that they feel and understand what care should look like. I have to say, really personally, just 2 weeks ago, as we're building this thing, this idea of a patient's union has always been a dream of mine in my worst moments navigating and battling corporate healthcare. And 2 weeks ago, I was dealing with my PBM, denying a medication that I really needed for my neurological condition. Yet again, I deal with this every 6 to 12 months. We make the same cases every time they deny, several times wrongfully. And this time I was completely out of the drug and was in a really bad way. And as a result, I had to miss work to spend several hours, the work of building this thing, to spend several hours on the phone with my PBM and my insurance company and my doctor trying to figure out how to get the medication I needed. But I called up our team to say I got to miss this meeting that we're doing on claims denials to fight my own claim denial.
Wow.
And instead, our team said, wait, hold up. Well, why don't we just talk to one of our lawyers? And they're going to help, treated me just like a patient coming in our membership, did an intake, figured out what was going on, helped walk me through it, helped me fight, and then figured out a strategy for how do we fight so that we make sure that this doesn't keep happening to me. And then, we can think about a strategy of how to fight to make sure that doesn't happen for many other people. And I felt truly alone right before that on the phone with my health insurance company, and I knew I was no longer alone in that phone call and the series of phone calls that happened. And I think we can build something like that for millions of patients across the United States that both shifts how they can navigate this horrible and inhumane healthcare system right now, but also helps them put skin in the game for the radical overhaul that is needed long term. And I believe that with all of the pain that's going to be unleashed in the next couple years with the Medicaid cuts and the ACA premium subsidies, that there really is, I think this is the moment to build a patients' union. There's never been a better moment than now. The moment to help ignite an imagination, as you were saying, about what a radical overhaul of our healthcare system is. There's not a better moment than now, and it is hard work, but what I'm seeing from across the country, people across the country, is that people are ready.
Everything that both of you are saying is just so incredibly inspiring and empowering, and I just want to thank you for being here with us today. Let's give our panelists a round of applause for being here. Thank you. Thank you so much. Thank you. So we're about to break for lunch, but I just want to invite Nidhi, who I can't see, she's right here, to come up for one more minute. I'll say thank you to you all from the Century Foundation. This has been a really incredibly inspiring day, and I feel really energized for this work. But I want to thank AALP for doing the lion's share of the organizing. And Nidhi, I think you have a few more thanks to give.
I'm good? All right, okay. Almost at lunch, and everyone's sitting in their seats, so thank you so much. Something like this is really not possible without an incredible number of people rolling up their sleeves and doing the work, not just in the run-up to this event, but over the last year. So this day has really been moving. I don't know whether to cry both out of pain and out of hope, especially that last panel. So thank you so much for being so generous with your time. So a couple of thank yous. More Perfect Union events were the ones who helped us organize this entire event, everything that you're seeing. So just a big round of applause. They're incredible to work with. So thank you, Katie and team, Katie, Joe and team. Again, Julie, Angela, and Jean, it has been so incredible to work with you all over the last year, and I'm so excited for the continued partnership. Another partner of ours, More Perfect Union. This is the Emmy Award-winning journalism outfit. You should follow them on Twitter and YouTube. They were the ones who made that incredible video. They tell incredible stories about the working class, and they have also been incredible partners of ours for the healthcare work. All our coalition partners who took the time to join us today, just really such incredible attention and dedication in this room. And again, I am going away both really inspired, even though there's so much anger that we can harness. And of course, last but not the least, my amazing colleagues at Economic Liberties. I'm going to name check some people because this was a lot of work. So again, it's like putting on a Broadway show, right? And this wouldn't have been possible without our comms team. Allie, somewhere here in the corner there, she leads our comms team along with Paige, who's been live tweeting this, so you can go and retweet it, and Zach. Jake Willis, who keeps us all on track and got you all your logistic information, along with Cabrina, who checked you in, and Peter. Lily Solomon, a singular force in our advocacy team. She's right there. Our amazing fellows, Benjamin and Luke, who are also pharmacists, and Hayden, who you heard from, and Hannah, who couldn't make here. They're the ones who inform our healthcare work. But most of all, I really want to give a shout out to the two incredible women who are the force behind this work, Morgan Harper and Emma Freer. So thank you so much. All right. Now you get to eat and continue to plot about how we can take these people down. So keep in touch. Thank you.